That's one small step for man and one giant leap for mankind. These were the words from Neil Armstrong when he first stepped on the moon. So with this inspiring quote, I welcome you all for the scientific session on e-ICU, technology in the future of critical care, organized by Apollo Hospital, Navi, Mumbai, in association with the Indian Society of Critical Care Medicine, Mumbai branch. Thankfully, I'm associated with both. I'm your host for the day, Dr. Manoj Kumar Gatlawar, intensivist at Apollo Hospital, Navi, Mumbai, and executive committee member, Mumbai branch, ISCCM. I welcome you all for this scientific session. I'm privileged to be here today to host this scientific session and thank Dr. Akshay Chalani, the organizing chairman, and Dr. Bharat Jagyasi, the General Secretary, ISCCM Mumbai branch, for giving General Secretary, ISCCM Mumbai branch, for giving me the opportunity. And also I would like to thank our patron, Dr. Pratap C. Reddy, the CEO of Apollo Hospitals, Dr. Santosh Morate, the regional head, Western Region, Apollo Hospitals, Dr. Kiran Shingote, unit head, Apollo Hospital, Navi, Mumbai, Dr. Ravi Shankar, DMS, Apollo Hospital, Navi, Mumbai, and Mr. Abhay, Marketing Department, Apollo Hospital, Navi, Mumbai. In the era of innovation and technology, where many advances are coming up in the healthcare, like telemedicine, robotic surgeries, artificial intelligence, and so on, the Department of Critical Care Medicine is also untouched by this, and the concept of e-ICU is taking shape. e-ICU is a technology-driven approach to critical care that utilizes remote monitoring and telemedicine. To provide round-the-clock intensive care support to the patients, it involves a team of critical care specialists who remotely monitor patients in multiple ICUs using advanced cameras, advanced sensors, and communication technologies. This innovative approach aims to enhance the quality and accessibility of critical care, especially in areas with limited resources or a shortage of critical care specialists. As you are aware, most of India's population lives in rural area with poor access to specialized services. e-ICU can make a difference in their lives by providing expert advice in management of critically ill patients. Today, over the next few hours, we will try to understand the concept of e-ICU and how it will benefit a larger section of the population who are deprived of expertise advice. So, to start with the session, I would like to invite our chairpersons, Dr. Bharat Agrawal. He is a consultant physician at Apollo Hospital, Navi, Mumbai, and Dr. Badal Tauri is associate professor at MGM Medical College Hospital, Kamote, Navi, Mumbai, to chair the session. To begin with the introduction and our first talk, e-ICU, a paradigm shift, I would like to request Dr. Akshay Chalani to come on stage. Dr. Akshay Chalani is a well-known figure, he doesn't need any introduction. He's the organizing chairman today and a consulting physician and critical care expert at Apollo Hospital, Navi, Mumbai. And he's the chairman of ISCCM Mumbai branch and a national executive member from West Zone, ISCCM National. Just give him a big round of applause. Thank you.
First of all, I thank all of you for coming here actually on the Sunday, when already in Navi Mumbai 2 or 3 CMEs are going on and sparing your time. We'll see that at the end of the day it's worth that you are here, your time, whatever you are spending here. So initially when we thought of the e-ICU around before the COVID, there were very few papers or few instances in USA there was a concept of the e-ICU. But once after the COVID, then we realized that how to manage the patients who are in the remote area, how to manage these COVID patients who are critically ill. What happened basically if you see, remember in the COVID-19 and 20, every day the recommendations are changing. The people who are in the remote area, they don't know use to chloroquine, not to use a chloroquine. After that, use a remdesivir, not to use a remdesivir. So in that, I think in that process, this evaluation of this e-ICU and the concept of the e-ICU, the people came to know about the e-ICU, and subsequently we realized that at the end of the day, when you took a remote consultation or when you took an expert guidance from somebody who is not bedside to the patient, who is not physically present at the patient side, can change the management and can change the outcome. And subsequently it proved that yes, because every day during the CME, during that period only the Zoom, the evolution of the Zoom and all that, and then we realized that yes, we can manage the patient by sitting here in Navi Mumbai. You can manage the patients who are in the remote places of either Maharashtra or India. So then that concept evolves, and we thought that Apollo Hospital Navi Mumbai is always on the, not radar, but always we are the forefront of medical health, education and technology. So we thought that we will evolve this concept, and since it got sensitized that period of time, and I'm happy to share and announce that from last 2 to 3 months we have started the e-ICU at Apollo Hospital Navi Mumbai. Presently we are managing around 3 to 4 beds who are in the remote placed. So what that concept did, why it is required, I'll just explain in next 15 to 20 minutes. The e-ICU, basically what I'll talk about is paradigm shift. What exactly is the paradigm shift? Suppose you go to the dictionary and see what exactly it means. Basically it's very clear, it's important change that happens when the usual way of thinking about or doing the something is replaced by a new different way. As somebody else says, the only constant thing in the life is a change actually, and if you don't change by virtue of you or on yourself, you don't change, the situation will change you. So it's better that you change rather than the situation changes you over the period of time. So coming to that point, e-ICU, again that paradigm shift, what we talk about, it's universally recognized scientific achievements. It happens when situation or anomalies occurs when no longer fit the expected pattern to such an extent that the original paradigm needs to be rethought. So what I mean to say, it's possible that over the years we are doing practice. But at one point of time, we just need to think, we need to not only learn but de-learn also that whatever we are doing is right or wrong. So years together, to just give an example, we used to use intracardiac adrenaline when we did MBBS around 20 to 25 years. Now it's no more practice. So there is evidence, there is a study, it showed that don't use this intracardiac adrenaline. Over the period of time, we use dopamine. Now dopamine is absolute. You won't find I won't be surprised in next 2 to 3 years, you won't find dopamine in the ICU. So over the period of time, you just need to change. That is the real thing which I come to the point now. As the time evolves, you need to change, and you need to change significantly to survive actually. So what are if you see the medical literature, I'm talking in the context of the ICU actually, what things have changed. One is monitoring. Initially when I started my DNB medicine in Sion Hospital, that time we realized that we used there was only one monitor in the ICU. 1 or 2 monitor are out of 10 beds, and every monitor will show to the BP every 15 to 20 minutes. So that point of time around 2001 and 2002, the technology, we felt that it is most advanced technology, but over the period of time we realized that every second, every minute you know what is the blood pressure, every second you know what is the cardiac output, every second you know what is the perfusion pressure. So you can plan your things, you can change the treatment, you can modify the mortality. So in the critical care we found that we are changing from monitoring, which was initially intermittent, now it's continuous. Second, too much is too less actually. Initially, few studies showed you give an antibiotic, you give a lot of IV fluids. To just give an example, now it's very clear that once septic shock develops, you don't give too much of IV fluids, you cut it down because there is edema and other things. So over the period of time, we are realizing that second is death is a good outcome. This statement is from the medical literature. It's not that the death is a good outcome. At the end of the day, when there is a terminal malignancy, you know that nothing is going to happen. There is no point in extending the pain of the relatives, pain of the patient. So sometimes a dignified death is a good outcome. Randomized trials is the only evidence. Whenever we do practice, we ask ourselves question, whatever I am doing, whether it is evidence-based, but it's sometimes possible that you need to take a decision, not only the evidence-based, but depend upon the local scenario, what are the case reports. And checklists are the more important than the protocols. Mind you, you are in the hospital, you are in the clinic, you are in the ICU, any administrative post. Only if the SOP works, we won't require anything. When the SOP doesn't work, you require intensives. When the SOP doesn't work, you require a CO. So what I mean to say, SOPs are made so that the most of the time you don't miss most of the things. But when the thing doesn't work, you need to change something. That is the reason that there is an administrator, that is the reason that there is a doctor, that is the reason there is a human person. Above that, the reason for which we are here is to expand beyond the physical ICU. Now we have seen there is a physical ICU, there is a doctor, there is a 20-bed ICU, intensivist, nurse are managing. Whether we can do something beyond that. So what exactly is that? That is the e-ICU. And what are the functions we want to cover in the e-ICU basically? One is to cut down the load. As you see in India, there are a lot of, you see the number of patients, number of beds and number of ICU beds. There is a gross disproportionate. So to cut down the ICU load, we put on the RRT, rapid response team on the floor. If the patient, there are certain parameters, BP goes up, BP goes down, the team gets activated, and you take measures. You took a measure at that point of time and the patient became okay. ER, now you see most of the time in the emergency room, most of the things are done. So we decongest the ICU. Ambulance now in the trauma or most in the cardiac and stroke patients. We thrombolize the patient in the ambulance. We thrombolize the patient in the, for stroke, for heart disease, we thrombolize these patients in the ambulance or at the remote places. Again, so the reason why we are here is the e-ICU, whether we can do something beyond this physical ICU structure is the e-ICU. That is the reason we are here. Now, whatever I talk, whether it makes sense or whether there is a scientific evidence or whether it is time proven, yes. So what do this concept of the e-ICU first came in the USA because there is a shortage of manpower and all that. So what they found that whether it is really working. So can we make this clear? This is not clear on screen. Morning only I told you. So basically, this number of hospital ICU telemedicine increased from 16 to around 213 actually, from 0.4 to 4.6 in 7 to 8 years. So there is a need for this e-ICU actually. The average annual rate of ICU bed coverage growth was around 110 per year in the first 4 years. So what I meant to say, we follow the Western literature, we follow the USA people, but whatever said and done, we discussed at some point of time, but there is an increasing in the demand actually, and that is evident from this article in the Critical Care of Medicine. So this is number of ICU beds covered by the telemedicine increased from around, this is around 550 to around more than 5,000. Sorry for the clarity. This was the article I took from the Economics Times, what they found that India tele-intensive care unit market revenue will increase from, we are here around 2013. So they expect that in 2027 it will go around, I don't know how many millions, but there is a significant increase in this graph actually. So we need to know what is happening in the year. Now coming back to the question, why you need a e-ICU? Is it possible that without e-ICU you can run the show? No, because there is a lot of trained, there is a lack of trained people, nursing staff, intensivists. This high severity adjusted mortality and long length of stay rates. I'll touch this point afterwards, but it is found that it's not possible that every time we'll get a qualified people along with you. Sometimes suppose you are sitting here, it's not possible. Patient has a myocardial infarct in a remote area. By the time he or she comes to you, it's possible that golden thread isn't off. So whether we can do something to either thrombolize or do something to give antiplatelet to these patients. So safe transfer of the high acuity patients is not possible, and it is, if you delay the treatment, you delay the intervention, the outcome will be a little problematic. So sometimes it's possible that the part of an organized structure that support hospitals around more than 500, 700 beds, there is ER, there is a floor, 10th floor patient, then e-ICU. It's better to monitor and have a e-ICU with you. In COVID and flu, when there is a lot of issue with the contamination and infection to other people, you can explore the option to use a e-ICU. Manpower, nursing staff, I already discussed in India. Qualified and good people, always there is a problem. Basically, e-ICU in India, how to track your performance. Any school, you take any service industry, either you take a school, hotel or hospital, how do you know that you are working good? How do you know that whatever you are doing is good? Either you self-analyze yourself or you do some parameters or you do some quality indicators where you, at the end of the day, you know that whatever you are doing is less. Suppose there is a mortality around 20% every year. What you need to do something, but it is not matching the international standards. Whether you can do something so that it goes down. So how do you know that this is happening or not happening? So that is one of the way that you monitor the things in the graphical manner, and then you can use this information technology to fundamentally improve your operating efficiency and enhance the safety. Sorry, that medicine has been shown, and whatever I know that basically as a medical person or as a doctor, we are the last to adopt the new strategies actually. That is the reason. How does this e-ICU works basically? It is just a live telecast. What I mean to say, we see a cricket match, something happening in Bangladesh or Sri Lanka. Within the fraction of 5 to 6 seconds, we know what is happening there. The same thing applies to the e-ICU. Suppose you are sitting in Apollo Hospital, Navi, Mumbai, and you want to see something in the Calcutta. So what they will do, they will just put the camera, they will put the audio set, and whatever is happening with the patient, the same monitor, the same parameter, the same rhythm will reflect here in the Navi Mumbai center. So what exactly you know, suppose the patient has some arrhythmia, at least you know that you need to do something intervention. So it's basically live telecast 24/7. Audio video monitoring, and there is a medical legal. The question will be again asked, what are your medical legal implications basically? The person under whom the patient is admitted, he or she is the primary responsible for that. We have the second party for that. So it's not that always the person who is responsible to manage the patient, at the same time we are also responsible. But this is a gray zone. This is not very scientific statement. This is a very gray zone because from last 3 to 4 years only we are doing this e-ICU. What exactly happened in case there is a medical legal issues, I am not very clear, neither anybody is clear, but whatever little bit I understood, the primary part is the consulting physician or the person who is treating under whom the patient is admitted, second are we. Now, what are the advantages? Basically, there is novel data presentation formats, you can computerize decision support, alarm system is smart, you can enhance the efficiency, there is increased effectiveness of the staff and standardized clinical and operating procedures. Now, at Apollo Hospital, what we have, we are a good team of good intensive supported by the good physician and other specialties. Can transfer the ICU into the center of excellence successfully on the hospitals, accepting the underlying the value proposition. Ultimately, what I need to understand that the physician should be able to change himself or herself. That is the reason that the e-ICU will work. Advantage, you retain the patient. Suppose it's possible, suppose somebody is there in the nursing home at remote places. He is shifting approximately 10 patients per year, per month to some any other tertiary or quaternary hospital. Sometimes you realize that the same thing has been done which is done in that remote place to here. So you can retain the patient, not every patient, but most of the patients. Suppose you feel that same expertise or guidance can be given from here, you can retain your patients. It will ultimately cut down the cost, and error and second opinion, basically 2 people are seeing the patient, you only at your bedside, and we are monitoring from here. So it's very unlikely that you will miss something, unlikely that 2 people will miss something, and it is beneficial for the hospital also and you also actually. Proof of concept, now somebody will ask, is there any literature or is there any evidence or is there any studies had shown that whether it will help or not. This gentleman, Mr. Ajit Dhakal, he wrote one article in 2000 JAMA, this Journal of User Driven Healthcare. So what he found, basically, he studied more than 700 patients. Those patients who were monitored by the e-ICU, there is a decrease in the code blue, decrease in the fall of the patient from the bed, mean stay in the ICU has cut down, mortality rates are decreased, and the complication rates are high. So there is enough evidence, though it is not robust evidence, but whatever the data we available, it shows that there is a significant evidence to show or to make a statement or at least sensitize the subject about that, yes, e-ICU might decrease this. Now, this is the Indian data. This is the gentleman who wrote an article in this JAMA article, use and misuse of ICU telemedicine. So what he wrote, basically, the mortality in medical, surgical and cardiovascular ICU is same, but mean length stay of hospitalization. If there is a e-ICU based, the mean stay is around 9.8, but if it is non-e-ICU based, it's around 13 days. So you can save the cost in both the indices. Now, if the government is working hard on that, why we should be behind? Basically, AIMS has planning to implement the e-casualty e-ICU for a more remote monitoring of the patients. If government is serious about that, I think it's high time that we should be also serious about that. This is my last slide. Conclusion, basically, with that, it's a need for an hour. The idea of you innovating is not that everybody should opt for that e-ICU, but just get sensitized that one of the possibilities or one of the issues, or when you are tired or stressed out, you can think of e-ICU when you are nursing home. We need to adopt the technology. Neither you should be the first to adopt that, neither you should be the last. It's like new medicine. Always we are keen to prescribe that, but at the same time you need to know what is pharmacology, pharmacodynamics. You should not be always first to use that, at the same time you should not always the last to use that. So at the right time you take a decision and use that. The same thing applies to the e-ICU. It will cut down your stress and cost. Every time it's not possible for you Saturday night, Sunday night, Friday night to just be on the, and whenever you are more relaxed or whenever you are, what I found that more comfortable, something wrong will happen and the whole night and whole day will scoot off. So you can share your responsibility other than your finances. That's all. Thank you from my side. I'll be happy to answer any questions, but my colleague and team from now, next 2 to 3 hours we have all topics covered, but at any point of time I'll be happy to answer your questions or query. Thank you, Chairperson, for your time. You can please ask. So basic infrastructure, the most important is your internet connection. So that power of that interconnection is around 128 or 123 MHP. That unit I don't know, but you should be the normal Wi-Fi which has a good connectivity. That is one thing. Second, you will require one cart. It's like camera, moving camera. That will cost around 3 lakhs. it will be located in your ICU, in your nursing homes. That will move from all the patients. These are the basic two requisites. And the person who is at the bedside, he or she should be able to communicate with you in the language which you and everybody knows that. This is the basic cost, sir. Cost at the end of the day, when you consider benefit, risk and outcome and patients, within 6 months it should nullify, sir, if I understood everything correctly. Thank you.
Thank you, Akshay sir, for that insight into the e-ICU. Now, technology has enabled faster and more accurate diagnosis, improved treatment plans, and enhanced patient outcomes, be it continuous heart rate monitoring, blood pressure monitoring by our smart wearables, or keeping records. Technology is playing a greater role in our day-to-day practice. So to speak on our next topic, leveraging technology, I would like to invite upon stage our next distinguished speaker, Dr. Gunadhar Padi. He is a senior consultant at Critical Care Medicine Department, Apollo Hospital, Navi, Mumbai. Please, sir. Give him.
So, good morning, everybody, my dear colleagues, intensivists who are all here, all the physician practitioners. And this, my talk is basically more focused on the technological aspect and how technology can collaborate with the medical science to have a win-win situation. Because everybody, when we are students, we are all reading the books. We are reading the books and we are practicing and we are seeing the clinical patient. But now the technology has evolved to such an extent that everybody everywhere can be connected, and you can have all the resources and you can use the technology to improve yourself, as well as you can leverage the technology to have a good outcome for your clinical patient. So that is what actually the basis of the talk. So there are various different technologies in medical science which we can use. I will particularly focus on the part of this technology like called the e-ICU technology. But I'll just have a brief introduction regarding all the other technologies which are we can use and we can improve and upgrade ourselves. Okay, so this is the topic outlay, basically the different technologies of healthcare and how to use it. Leveraging of technology, what is the definition, the advantage of leveraging, the most common technology and its application, the disadvantages, process flow of telemedicine, summary, and the what is called the take-home message. So as all of us know, this is the golden days where we have started with a small basic computer, and now where we know everybody where right now we are there. Actually, the technology has far advanced, and every field, whether it is a medical, IT, it's a business, it's a finance, everywhere, everybody is using this technology. And this is the next technologies coming up in the healthcare in a big way, basically. You can say artificial intelligence, all these like the mobile social internet, the blockchain technologies, the cyber security, cloud computing, the quantum computing, and all these things like which are actually going to revolutionize the medical field. And if you don't adapt, if you don't go with this technology particularly, then we will be lack. And that is why these are the best 10 technologies which we can actually focus on. The smart inhalers, robotic surgery, the wearables, brain sensors, 3D printing, artificial organs, the health wearables, precision medicine, virtual reality, and of course telehealth, which is the most commonly adopted and which is actually practically, it's now we are able to see this. And of course the other genetically technology like CRISPR. And the trends in 2020, if you see, the best and the most commonly used technology is the telehealth, and of course something called as the tele-ICU. And this is what I just wanted to tell you. In 2009, this is the scenario. But in 2019, we see now both the job of the pilot as well as the cameraman both at the risk. So we should not put ourselves in the risk. Rather, we have to use it to improve ourselves and to improve the clinical precision in the clinical medicine. So what is basically called the leveraging? Leveraging is nothing but basically it is the use of technology by expert, by the physician or the intensivist to have a good outcome, good clinical data recording, and it also use the state-of-the-art resources and employs technologies to assist in the work activities to reduce the stress. And this is called the technology. So of course, this has a numerous advantages already told by Dr. Akshay. So not to point out all these things, everybody knows it has a huge potential for marketing opportunities, customer satisfaction, access to data and analytics. It makes us error-free. Now the most important thing is, of course, the chances of error, if you use technology, is very, very less. The precision is more accurate, and of course, that's what we need in clinical medicine. So everywhere, these are the literature which suggests that, though the history of telemedicine is starting from 1977, and we are standing at an era of 2023. So you can see these are the different datas, like the Christopher Mims, ICU leverage remote doctors and telemedicine to manage the coronavirus surge. Basically, the use of the technology was best achieved during the coronavirus spike. So, and everybody knows this is no doubt about it. So the hospitals fast-track remote technology to manage a surge in critically ill COVID-19 patient. And of course, this also protects the on-site healthcare workers and also saves the life of a lot of physicians and intensivists actually who are working for it. Leveraging digital technology to enable a more equitable distribution on the healthcare workforce is also a well-known fact. So the commonest technology is the telemedicine, and we all know this is basically a point-to-point contact, point-to-multi-point contact, and multi-patient to multi-patient contact. Like you can have several patients who are connected to several intensivists. It is not only limited to Navi Mumbai, but it is across the world, across the India, and across the small cities, particularly in the rural population. The same question I'm going to answer now, this was being asked. So this is the basic structure of an technology called the e-ICU technology, where we can see, like, this is basically, if you see here, basically this is the console, or here, basically the intensivist who is monitoring the patient, and these are the patient data. So the data is being transferred from the other ICU to the center or the command center, and you need all this process flow. Like, example is like the patient is here, all the monitoring, that is point of care monitoring is being transferred here. The intensivist can able to have a video chat, video connection, as well as the audio connection also. And he can also able to access the electronic medical records, and also he can give the advice, and that is being transferred to that particular center. So in the simpler way, this requires an audio-visual unit as well as the electronic medical record connection. So the audio-visual unit is very, very simple. It has a camera, like as just now discussed. That camera is being capturing all the data of the patient. Of course, the bed which need to be monitored, there is a consent and other things are required, and those data are being point of care or real time this being transferred to the center or called the command center. Like in Apollo Hospital, we have a command center, so those data are being transferred. And this is the camera actually. If you see, this is the high definition, or you can say the specific camera or specialized camera, which actually the cost is already being discussed. But the advantage is that it can see the pupils. In fact, this camera is unable to see the pupils exactly like how we examine in the ICU patients. It can see the chest movement, it can see the endotracheal tube, it can see the secretions, it can see all the vital parameters of the patient starting from head to toes. It can monitor and it can store and it can transfer, and the intensivist who is sitting at a command center can able to assess the patient clinical condition. These are the switches, so whenever you don't require the tele-ICU or the information or the audio-visual unit to get transferred, you can just switch off the things, and whenever the person who wants the information, the staff can switch on the camera and the camera can real-time transmit the data. The only important thing is that you should have a very good internet connection, because this is all being wirelessly transmitted. So otherwise, this system shows a lag, which is not acceptable. And this is basically the command center. The person who is sitting in the command center, he monitors the screen. So here we get all the real-time data, patient's vital, patient's record, patient's electronic medical records. And this is called the audio-visual technology. So this is basically not a one-way communication. This is called the two-way communication. So the staff or the doctor can chart, he can take the advice, he can suggest, and the intensivist can also suggest something when the patient is crashing or there is some need for the patient. Also, the integration of the electronic medical record from that hospital also can be possible, and those record the intensivist can see, and he can also write his note, and this is called the real-time data monitoring, which is very, very important. And this is, you can show all the live data, the live recordings, and all these things where the doctor is seeing here the vital parameters, here the CT scan, the X-rays, the real patient, their actual appearance, and you can also have a clinical judgment and to know whether how is the patient is. So basically the tele-ICU is a remotely monitor and support critically sick patient in several hospitals. ICU mortality rate has dropped almost to 45%, and duration of stay also has been dropped to 27%. This is a outside data, not the Indian data, because still the studies are ongoing. A lot of areas are still grey, medical legal aspect, ethical aspect, but I think soon this is going to evolve. Next 2 to 3 years, this is definitely have some important roles. So is it worth to invest and start? Yes, of course, what the evidence says, these are the different evidence from the outside world. So study says that the tele-ICU tools worth the investment for the hospital. Tele-ICU saves money as well as saves life. As well as you can see there are the different technologies that healthcare leaders are using or planning to use to reduce their impact of workforce shortages. So if you don't have good qualified intensivists, the numbers are less, and you want to take the advantage of this, you can take that. These are the different studies from the different hospitals across the United States of America, delivering the right stroke treatment faster. Thrombolysis can be done. Thrombolysis in acute MI, acute stroke can be done. And you can see they have all taken the leveraging of these good, important technologies. This is a study from the Carolina Hospital, and this is the study from the Emory Hospital, improving outcome while saving the money. And this is also the study from different hospitals, like this is Presence Healthcare, the success story, the standardizing care through the tele-ICUs, and this is also another important article from the Northwest Health Center, from fragmented to coordinated care. So all these westernized data are very important for us to formulate our own plan of action and formulate our database. Similarly, the translating quality into safety, rounding with the intention. So this has basically two parts. One is the digital healthcare system, where digitally you can access the data, as well as you can also have something called as the one-to-one interaction for the different your opinion. So these are the different papers. You can see the papers are from 2011. It is not new. Actually, it has been evolved from that time. So leveraging telemedicine for quality improvement, video review by critical care ICU events. It is a multidisciplinary form of education published in the PubMed. How hospitals in COVID-19 hotspots are leveraging the tele-ICUs. And of course, these are going to the future. So scope to expand. Of course, if you don't adapt right now, if you don't adapt ourselves, improve ourselves, we don't have the scope to expand. So what are the scopes in the future? e-ICU acute care program. Like Dr. Akshay already told, you can connect your emergencies to also the tele-ICU. That is from the telemedicine. All the emergency or casualty. Second is called the connected healthcare. So what is the connected healthcare? Now every patient is being connected, every sick patient, every vulnerable patient is being connected through different devices. We also have enhanced connected care in our hospital, where you can put different devices, wearable devices, and you can remotely monitor the same patient in the ward, so that any fluctuation in the heart rate, blood pressure more than 20% or 30% above or below, immediately the signal can come to the your central locations. This is called the connected healthcare. And going forward, most of the hospitals in India, they will have this technology that is called the connected healthcare. And of course, now the future is the avatar-based monitoring. Like in this picture, if you see, so here basically every patient is being represented by an avatar, and all the things which are connected to the patient, the data will come in the real time, and you can able to see that what is going wrong with the patient, whether the endotracheal tube is in the right bronchus, whether the ECG is not showing proper reading, whether there is arrhythmias. And of course, this is the future, what I called is like the hospitals, like critical and acute care programs. So you can have e-ICU for the ICU setup, e-acute care for your emergencies, e-consultation. So you can only take e-consultation for different patients for the different specialties, and tailored ambulatory care, like for the ambulance services like stroke ambulance, your cardiac ambulance, and trauma ambulance. Those services are also being integrated there. And this is called the ICU of the future, where you have visit to the intensive care 2050. So you can see these are the different the technology which is going to come, like from the genetic analysis you can see the organ, something called the physiological organ analysis system, to the organ reconstruction. Now the artificial organs, artificial heart, all these things are going to come into play because of the 3D printing. And this, of course, definitely going to change from the precision medicine to personalized medicine, like protocolized medicine to for specific subgroup of population, the syndromic approach of the medicine, and this is going to the ICU of the future. So ethical consideration, the patient safety and data security, still all these are in the gray areas. Informed consent, autonomy, very, very important. This is basically a mutual coordination where both the party has to understand and they have to take in and share the responsibility. Equitable access and disparities should not be there. Professional oversight and responsibility should be equally distributed by the mutual consenting. Quality of care and accountability should be must. And these, but of course, every technology has the disadvantage. It is the person who knows how to use it and what are how to neglect the disadvantages. Like, while it reduces all the mortality, the stay, but of course there is a small component of cost. Of course, that is definitely there for every newer technology. So that has to be balanced. And in my last slide, I can always say the 2 eyes are better than 1. Always share the responsibility and improve the patient outcome rather than taking all the burden on yourself. Thank you. Any questions we can discuss right now? Okay, thank you.
Thank you, Dr. Gunadhar, for that elaborate view on e-ICU. I hope people might have understood how it works. Now, I'd like to thank our chairpersons for sparing their precious time. I would like to invite Dr. Shailesh Parekh to felicitate our chairperson, Dr. Bharat. Now I request Dr. Mangesh Mehta to felicitate our chairperson, Dr. Badal.
Just take a liberty at any point of time. Suppose you are free in Apollo Navi Mumbai, we have this e-ICU setup. So whenever you want to come, 24/7 it is working actually. So you can come to any time at 4th floor. There is a e-ICU. Right now we are managing 3 or 4 beds. So 24/7 we have staff there. So I'll just give you an example what Dr. Parekh sir has asked basically. So what we do basically, one sister is sitting, or one nurse who is a qualified nurse. She is sitting in front of the console. So on that console there are 2 patients' videos are there. Suppose the patient is in remote area nursing home. So there are 2 beds. In one console, the 2 beds are seen. At any point of time, suppose you go. So like one laptop, you just assume that there is one laptop. In that laptop, right now you can see the 2 patients. And these patients are monitored from remote. They are in the remote places, but sister monitor here. So the plan of action, what we wanted to do now, right now the 2 patients are managed. So on the second console, one sister is sitting. She will manage the 2 patients. So it's unlikely that she will miss out something. Now suppose the patient had a bradycardia at remote place, heart rate around, managing on 70, and so it dropped to 60 or 50. So what she will do, she will escalate that. So what she will do or what he will do, he will call us. So our e-ICU is in the 4th floor ICU nearby. So always there is 24 hours, there is one person intensively sitting there, managing the physical patients. So first she will inform him that there is a problem. So there is a bradycardia. What is the significance of all that? That intensives take care. So intensive will immediately call that, suppose you assume that there is in the Panvel. So intensives will immediately call the doctor who is treating there. So he will tell him, by this is the problem, the patient heart rate dropped from 100 to 70. Either you see the temperature, or either you see some beta blocker you are using, or there is something, you just look into that. This is one alert. Now suppose even after 5 or 6 minutes, we are not able to contact him, or now the heart rate dropped from 70 to 50, or it suddenly went to 130, he will again escalate to that doctor who is in front of the patient right now, that is on the bed. But suppose in 2 or 3 minutes, action has not been taken. whatever he or she does at the remote place, suppose at a Panvel, he has not taken any action. He is not able to find out what is the reason the BP has gone down or what is the reason the heart rate has gone up. Then he will immediately escalate the chief intensivist who is there in the ICU right now. So next, this will happen in fraction of seconds, 5 to 6 minutes. So he will escalate to the chief intensivist who is there sitting there. At the same time, then we'll escalate directly this issue to the person who is under whom the patient is admitted. Suppose the physician who is managing the Panvel. So what we will do directly, our intensivist will call him, but there is a problem. This patient is not doing well. There is already in the last 5 minutes the heart rate is going down, the BP is going down, the oxygenation is going down. So what he or she will do immediately, we call the primary physician. So this is how generally we work. The same applies if the oxygen goes down. The same thing applies if the output goes down. So by and large, unless there is a dire emergency, suppose the patient has suddenly VTAC or VF, so immediately then we will escalate everything to every person. The person who is the bedside, the primary consultant, here if he is the chief who is sitting here. So it's like blue code. Suppose there is a cardiac arrest there. So everybody at the single within, the lag is not more than 2 or 3 seconds. So what I mean to say, it's very unlikely that even if you see the cricket match, there is a 10-second delay. As per government norms and all that, suppose there is a 10-second delay, whatever I was reading in the last few days. After 7 to 8 seconds only, you will know that these things happen because to avoid some any untoward incidents and all that. So here there is no delay. The only prerequisite that Dr. Parikh has said, the only prerequisite that the power of the internet should be very good. The bandwidth should be very good. So if the bandwidth is very good, now we observe that there is an issue with the electricity, there is issue with other. So that point of time, we should have a backup like what we keep in our home. So this point of time only there is maximum 2 or 3 second delay. So even if there is a VTAC or life-threatening ventricular fibrillation, the utmost care has been taken off. And over the period of time, suppose everything goes well. So what we do basically, we train staff who is there with you. Now suppose you opted to go with or affiliation with the Apollo Hospital e-ICU. So what we'll do over the period of time after 2 or 3 months, suppose we found there's attrition in every industry. So your staff goes. So what we'll do, if you are okay, our staff will come there and your staff will come here for 5 or 10 days and we'll train them. So that how we think of what we expect from them at the spoke center or hub center, the same thing be percolated here. So these are the little advantage to start with. What I mean to say that it's very, very unlikely that we'll miss out something. Unless there is a major power failure or something like that. So, and it all depends upon how the data is transferred from your center to the center, our center. So whatever you feed there, whatever we can see here, suppose you did not put the monitors here. So we need cooperation from you people, from those who are the hub center actually. So the more detail you give, we are in the more better position to handle the situation. This is basically idea, but the idea of talking me is, at any point of time, you are most welcome. Me, Dr. Gunadhar, Dr. Suhadeep, Dr. Divya, Dr. Bagul, all are there in the around, or somebody at one point of time you will find somebody. So they will take you through the EIS to how the system works.
Moving on to our next session, I would like to invite Dr. Chetna Vaishampayan. She's consultant physician at Apollo Hospital, Navi, Mumbai, and to chair the session. And Dr. Prachi Sankhe, she's on her way. She's running a little bit late. So just to call up on our next speaker, Dr. Mahendra Bagul, to speak on challenges and bedside and command center. So he's the consultant at Apollo Hospital. Consultant critical care physician at Apollo Hospital, Navi, Mumbai, with prior experience in e-ICU at Apollo Hospital, Hyderabad, and he has managed e-ICU for several years at Apollo, Hyderabad. So please, Dr. Mahendra.
Good morning, everyone. So, good morning everyone. A brief base of introduction and everything, my colleagues and my senior Dr. Akshay sir and Gunadhar sir has done. The basic, what I want to tell you is, yes, who is no more a new entity now. It has become part of the medical health center, and many of us are now using the technology of e-ICU. And this e-ICU is having challenges, but we know that as a human being, we are ready to take the challenges, and challenges have some solutions. So first of all, we see what are the challenges are there. I guess you have understood the basic concept of the e-ICU. If we see in a simple way what is e-ICU means, some expertise is observing a patient in the remote area, and he is giving his thought concept of the treatment for that patient. Okay, this is the concept of the e-ICU. So what we do in this, we have to see the patient and we have to tell. So it is similar like you're chatting on the mobile, or you're calling, video call you're doing. What are challenges we are getting on that one? The challenges, the same challenges we get here, but we have solutions to that. So how does a tele-ICU work? A two-way communication between the observer and the remote hospital. Technology helps to transferring the information. So what technology we use for this transformation of information? This is internet, we use it. Wireless gadgets are there. Satellite services are there. Telephone media is there. Then the team member which are involved for giving the information to the remote area are clinical team that is consisting of the intensivist, clinical expertise nurse is there, advanced practice provider is there, non-clinical team that is data assistant, clerical support for the e-ICU, technical supporting team is there, and for 24/7 the technical support team will be available, and the reporting analyst will be there. At the receiver hospital, a skilled intubating doctor is required, a skilled nurse is required, proper information of event to be sent to the e-ICU doctor. This is the foremost and the most important challenge what we faced. I faced in the Hyderabad when I used to do the e-ICU. But challenges have solutions, I told you. So we'll see how we get the solutions to all these things. So challenges basically faced, first technical and non-technical. If you see the technical challenges I told you, the command center, the center from which the expertise gives his opinion to the remote area. There we get the technical challenges. Even at the remote area, we have the technical challenges because they have to give the information to us. Second, non-technical challenges that I told you, non-clinical people are also involved in this. Non-clinical things are also there. So that challenges are both at the command center as well as the remote center. Okay. First, in this challenge, the most important thing is to safeguard the things at the command center. Means we have to keep all the data and everything very much. It is a medico-legal data. Okay. So the administrative data privacy, everything has to be maintained. The physical hardware maintenance. See, when you do chatting on the mobile, we have to do the maintenance of the mobile. We put the cover, we do the servicing, we put the Godzilla, what we call it, some cover, we put that one. So all these things are there. Now we do it. Why we do it? Because we want the hardware, our mobile to work properly. The same thing is here. We have some hardwares are used here, the gadgets are used here, they have to be maintained. The smooth connectivity, 24/7, the internet has to be there. People has to be there, non-technical people who are taking care of the internet, they should be available there 24/7. If a technical glitch happens, they will come immediately, they will solve it, because the main motto of the e-ICU is 24/7 monitoring. What we see, teleconsultation is different, and telemonitoring and tele-ICU, it is a part, basically the part is the monitoring, and the monitoring part will help to give good output of the patients. Then administrative safeguards, I already told you. Technology era is rapidly evolving. The threat to the computers by new viruses are also increasing. So we have to keep all our computers safe. Access to the computers area of e-ICU should be restricted. So whenever we at the command center, we have that thing, no, we are not allowing many people to come there, because they will just start pressing any button, they can't speak anything, or the data may get erased, all these things. Then yearly antivirus upgrading is also one of the important thing, and upgrading the instruments is important. Data saving is an important task. That is a medico-legal data, what we are sending to them and what we are getting from them. Physical safeguards at the command center, as I already told you, is the area of the command center should be restricted, access to the computer should be restricted, damage of the computer or non-working of any computer part has to be reported to the authorities concerned and has to be at the earliest repaired. Computer monitor privacy filters to grant against unauthorized view of the information is always kept at the e-ICU. And technical safeguards at the command center, installment of large manpower, let access to only authorized personnel, sophisticated hardware maintenance, time-to-time upgrades and updates of the software, uninterrupted continuous internet connectivity. The same thing what I explained to you is I have elaborated in this slide. Then at the remote center, now I show you, this is the cart actually. This is the cart and this is the camera. If you see, this is the camera which rotates 360 degree. And this is a screen on which we see the patient. There, that doctor, when they talk to us, we can see the doctor on the screen, and this is the camera which rotates like this, 360 degree. So the pixel of this camera is very high. As Dr. Gunadhar already told that, we can see the pupils, we can see where the ET tube is actually, we have at what size the ET tube is there, whether there are secretions are there or not. All these things we can see because the camera is so, we can do the zoom of the camera also. Okay. So the cart has to be safeguarded. Initially what happens when the new ICU were there in Hyderabad, when I was there involved in the first ICU, cart seems to be to some people, means the owner used to know, the hospital owner, it is a very important and it is a very costly thing. But the doctors, nurses, they always used to come in front of the camera. In front of that camera, they used to come and they used to say hi to us. They used to go from there and someone used to come, they used to press the button there. So we started a policy and we make them understand, no, this cart is a very important, it is a costly thing. We have to just maintain everything about this cart. The important thing is that if any of the buttons get damaged in this, the repairing is only done from the Delhi. Because these are the Philips carts are there. So from that time, everyone started how to safeguard all this cart and everything. Then we made a policy and we told them, only people who are authorized, they are allowed to come near the cart, and who are not authorized, they should not come near the cart. So this was the initial small challenges what we had. So this cart is an important instrument for the tele-ICU. It helps to give you audio-visual connectivity. It consists of a screen and a 360-degree rotating camera. All the staff of the hospital should be informed about the non-touching to the camera and the screen. Unnecessary on and off of the cart should be avoided by the staff. Okay. The technical safeguards. A good internet connectivity is mandatory for the smooth working of the e-ICU and also the cart. Hardware maintenance should be done regularly. Staff should be trained how to use it. This is one more important challenge what we faced is to tell them how to use the cart. Because the thing is that when some sister or some doctor, RMO or someone is told to come in front of the camera and speak something, so they get shy, they will never talk like this because they don't know what the other doctor will think, whether we are giving proper information or not. So in this perspective, what we have done, we started training them. What input they basically should give us. They should not tell us what any other thing more than that. We made some protocols. We gave them the protocols. And that according to that protocols, they used to come and read 1, 2, 3, 4. And they used to tell us, this is the thing, sir. So slowly they built up the confidence. Slowly they built up the talking, their habits also. And with this challenge also we overcome. Then sending the information. See, sending the information in this e-ICU is actually, we can tell orally also in front of this screen, as I told you. The second thing is that we have a special things that is called as screeners are there. On the screeners, if they write down the history or everything, we get the history, written history on this, on our side, on our screen. So this is one of the example I just kept there. So use of WhatsApp in emergency situation can be done. If the patient is got arrested, if the patient, any emergency is there, if they think that the information by screener, they can't go near to the screener, then what they can do, they can just send the things on the WhatsApp to us, we'll analyze the things and we'll tell them what can be done. Non-technical challenges at a remote center and at the command center. As I told you, the instructions given should be followed properly by the sisters. First of all, what we tell to the, what our, means when we see the patient, we have some thinking that this should be done to the patient. Okay. So initially it was a big challenge to make them understand what we are saying, that we told them fast hug, feeding, analgesia. So they didn't understood. That was then we slowly started training them. Fast hug means like this. You have to do 1, 2, 3 things, 1 to 4 like this. Then intubation reflexes. We know that when when intensive is the correct person to tell when the patient get intubated or when the patient should be intubated. Okay. So with that vision, when we see the patient on the screen and when we tell them, this patient may get intubated now. The initially reflexes used to be very slow. Ho jayega. Arey hoga na tab dekhenge slowly. Then we told them that it is not like that. When the patient is about to get intubated, when we are telling you, you should be ready with the cart. You should be emergency cart, intubation cart, everything you should be ready. So that challenge, when we saw that they are having very late reflexes, they are not able to start with with the pace what we are telling them. Then again, this challenge was there, so we started training them. We told them, this is not acceptable at all. When you have to give good outputs to the patient, you want your patient to be better, then you have to follow what we are saying. So we started training them. We had given the training to all the sisters, doctors, and all the paramedical staff about the ACLS, BLS also. Emergency cart, we made them emergency cart, how to use it, we told them. And initially improper CPR techniques were there, we taught them, we educated them. This is also one of the hurdle we have got the solution. Proper communication with the command center, as initially I told you, they used to hesitate, they used to not talk to us. Then we told them, we already trained them how to do it. And no documentation we found at initial, but we started making how to document the things in a proper 1, 2, 3 manner, and we told them how to send to us. This also was trained by us. Training and education of nurses and supporting staff is a must for running of e-ICU, proper e-ICU, because this is a most important challenge and the most important solution also to this. At the command center, the task of compiling all the audio, visual, and the lab data. When you see 1 patient, 2 patients, it's very easy to answer all the things. We can even remember the creatinine of the patient is 1. We can remember the output of the patient is 50 ml, 60 ml. When it comes to 25, 30 patients, and that we are trained to see every day by going to the bedside. We go to the bedside, we touch the patient, we feel what is happening there, we talk to the relatives, and we understand this is the scenario, and this is what we see, and we tell them, and immediately we consult the attendants, we do actually. But when it comes to the e-ICU, at the same time, if 25 patients are there, you want to take the round, you have to do all the things, it is challenging. But we have a set of protocols, we can do that also. This is not a big challenge. Everything is possible in e-ICU. And the best part of this is that at the same time, you can't see only 25 patients, you can see 50 patients, and you can tell them and you can guide the doctors what to do. Okay? Getting full-time nurses. That command center, we should require full-time nurses. That is means it is at the command center, that's the challenge. We should get a trained, a well-educated sister who knows what to be done, when to be done, how to be done, and when to tell the doctor, this is the part, now you should come, sir, now you should do it. So we should train the nursing point also. We should get such nurses at the command center. Full-time intensivist for 24/7 coverage. This is one of the important and very challenging for the command center. Documentation of the patient's monitoring. It automatically happens, and we have to just save the data, and bit-to-bit monitoring happens. What are the heart rate? What is the ECG pattern? What is the SpO2 of the patient at that point of time? So everything gets recorded. Plan of action to be executed at the earliest. So the challenge is whenever you see, you have to execute or tell to the respective RMO doctors on the other side what to be done, and make sure that your action is executed at the earliest. Just to quote studies which has helped e-ICU. In my next session also I will go more detail in all of the things, but just to quote something, and this is one of the study actually, Taro Vantade and Toro Konatani, they studied, actually made it, the evaluation of the impact and implementation of the tele-ICU, a retrospective observational study. It was done in 2023. This is a recent study. So in that study, what they have seen is it is actually beneficial to keep e-ICU, and it is how it is helpful is it helps to decrease the length of stay of the patient. Number one, in few studies, I will come in my next talk also, the mortality is also decreased. And the most important, what is there, this study also told that the stress level of the doctor is decreased in the, not to some extent, to more extent actually they have seen. So the most important point I want to tell you is the recent studies are coming up of the e-ICU because COVID has taught us that everything can't be done by a single doctor or everything can't be done by going near to the patient. So we can adopt e-ICU also and e-ICU services to give our expertise to the remote areas. This is one of the study, a telemedicine study that is done in Karnataka. And our critical care specialist, everyone may be knowing Dr. Pradeep Rangappa. Sir, he is from Bangalore actually. So what they have done, they have made a model actually of e-ICU. He is the pioneer actually. He is pioneer. He also, and one IS doctor is also there. His name is Trilok Chandra. So these two people, two doctors, Dr. Pradeep Rangappa sir and Trilok Chandra, IS officer, they have at the time of the task officer, they have set up e-ICU centers at 5-6 hospitals. The main objective of this e-ICU was to provide the critical care specialist services to the peripheral district hospitals. And it worked in such a beautiful way. They have wrote this abstract, this article also on that one. So they also seen that it is helping to the doctors for decreasing the length of stay, decreasing the mortality, giving the expertise critical care to the remote area where intensives are not available. So the challenges is the audio, video and digital platform to be integrated for a compiling of the information and to set up forward for the betterment of the patient. Thank you. Every challenge has a solution. Education, training are important to overcome most of the challenges. I hope most of the things are understood and the challenges are understood from my talk. If any questions are there, I'm ready to take. Thank you.
Thank you, Dr. Mahendra, for guiding through these challenges. And for the next talk on digitization, I would like to call upon Dr. Sudip Sen. He is the consultant at Apollo Hospital, Navi, Mumbai, to share his thoughts on digitization in critical care.
Good afternoon, everybody. Thank you for coming over here in the Sunday morning to share our thoughts on the digital ICU system. So in the next talk, over the next 20-25 minutes, probably we'll try to share how the digitization is having a kind of paradigm shift in the entire healthcare system in India, and especially in the ICU systems in India. We'll try to keep the talk less technical. We'll try to keep the talk more informative, try to understand why the digitalization is important in Indian healthcare system. So while I was researching on the topic, I just found out a very interesting article that has been published in the Intensive Care Medicine Journal, where author tried to visualize how the critical care will take shape in the next 30-35 years down the line, in 2050. So in next probably 30 years down the line, the precision-based medicine will evolve more and more. Like treatment of we do a sepsis treatment. The treatment of sepsis will be based on the genotypic mapping of the patients. The antibiotic dosing will be based on the real-time drug level in the patient's body. The end-of-life care decision will take place on some computer-based algorithm to which will decide the patient's chance of survival of the patient at particular time. and probably will go down more and more on the invasive monitoring. So we'll rely more on non-invasive mapping or computerized mapping of the patient's entire body system. So while they talk about all these things, but the best thing that this gentleman has told in the, probably everybody knows this gentleman. Mr. Steve Jobs, he told that the biggest innovation in the 21st century will be the intersection between the biology and the technology. And he has predicted that the digital health will revolutionize the entire delivery of the healthcare in next few years down the line. It will change the way we diagnose, we treat, and we manage and prevent any health condition. Now, what is digitalization in the ICU? Digitalization in ICU, it's a kind of definition, so we just found out, so there is no standard definition, but the definition that they have quoted, it refers to the integration and utilization of digital technologies and various data-driven process to improve patient care and streamline the healthcare operation. Now, what is all these things? We'll just come to know. Now, Indian healthcare system in the last 20 years has evolved in leaps and bounds probably. The technologies, a lot of Western technologies has come, lots of advancement, technological advancement has happened. But the two major challenges that still remain in the Indian healthcare system that we find is that there is a gross lack of standardization. We talk about, when we talk about the tertiary care center, quaternary care centers, they do a JCI accreditation, NABH accreditation. What these accreditation mean to us? They actually help us to maintain a certain rate of standardization in the entire hospital. But when you talk about the Indian healthcare system, where there's a lot of small peripheral setups, rural setups, they lack in that standardization. They do not maintain that standardization. So that is one of the challenges. And the second challenge is that we do not have Indian data of how the Indian people does in Indian setting. Most of the time we follow Western data. We take reference from the Western literature and try to implement those things in Indian setting. Most of the time probably they are right, but there are certain situations probably we should have our own data to understand our unique health challenges in the Indian setting. Now, there are two challenges where the digitalization can help a lot to prevent those things. Now, digital health is a paradigm shift to improve the healthcare system. Now, when you talk about the digital health, what is digital health? We started using, so everybody uses smartwatch now. So what is the smartwatches? So they give us the data of our heart rate, oxygen level in the body, stress level in the body. We use a lot of mobile health app, AIM Health app. They tell us that they are the cloud-based personalized health app, which gives the data of, depending on somebody's body weight and the height, they calculate the BMI, and they tell us how much calorie we need to take, how much energy expenditure we need to have. What does all these technologies do? They actually shift the care of the patients to your own individual. Like as an individual, I'm more concerned about my health. Suppose I'm running fever. My mobile or my wristwatch will tell us that probably we need to seek advice. My pulse rate is going up. So previously, whenever we are getting sick, we used to go to a doctor. Doctor used to tell us, okay, you're not looking well. But as an individual, when we are using all these app or these systems, that means that the care of the patient or care of somebody is more patient-centric, more individual-centric than a doctor-centric. So that is a major shift that has already happened or already started happening in Indian setting in the last 5-10 years, and that will evolve more and more. This AIM Health app, they have a kind of platform to have an online consultations, to have a kind of they analyze our own health data, and they tell us whether to seek doctor's opinion or not. Apart from that, we use a lot of AI-based or machine learning-based software, the blockchain software. They tell us more about the personalized medicine, and all these technologies, they usually they empower the patient or they empower individual to take care of their own health. If we talk about the WHO data, WHO statement, so they have also made a kind of statement in 2020. They published a statement where they also told that their aim is to develop a accessible, affordable, and scalable and sustainable person-centric digital health app, digital health solution to prevent, detect, and respond to the epidemics and the pandemics. Now, the digital health is a concept that is there probably in the Western countries for more than 20, 25 years down the line. But the major thrust for its development came in the time of COVID pandemic, where millions of the people were dying without any kind of supervision, most of the time without any medical help. So that point of time, we found out probably we need to have a kind of strategy where we can supervise a lot of people, even from the remote location. We should be more prepared to manage this kind of pandemic, and the demand for remote telehealth-based medicine and monitoring has increased. Now, what are the other factors which contributed to the digital transformation of the critical care? Is that first, there is a high demand of the demand of the critical care specialist, and the especially trained critical care specialist is increasing. And especially even in the rural areas, or the remote areas, where most of the trained specialists, they are unwilling to reach, unwilling to go, unwilling to travel. In those places, we can reach out with the digital platform technique. The ICU beds the need for the ICU bed is increasing all across the globe, all across the country, because everybody prefers to be monitored more and more. But nobody wants to go to probably, suppose I stay in a kind of remote area, of Maharashtra. Most of the time, I do not like to travel to Mumbai to travel and then get admitted in a tertiary care center. If I get a same level of care in my own place, probably that always is more preferable. So that is why this concept is increasing. Along with that, the complexity of the critical care patients is increasing. There is a need for better delivery of the medical care plan to the remote part of the country, and need for the affordable and the high-end critical care is increasing. Now, what are the aim of digitalization? The aims, first, to improve the patient care and the outcome in the ICU, to reduce the burden of the repetitive technical jobs in the ICU, to improve the patient safety and reduce human errors, which can be potentially fatal, and quicker clinical diagnosis, and to deliver the effective treatment, and to reduce the overall health cost. Whenever we talk about any technological advancement, it should come with the decrease in overall cost of that particular field. So digitalization in the ICU probably will decrease the overall healthcare cost. There are various forms of the digital ICU concept. It can be EMR in the ICU or in the hospital. It can be tele-ICU or various cloud ICU-based platforms which can take care of I'm sitting in a Bangalore. I can reach out to any ICUs in remote village of the Bihar probably. So those things can be done. Home care concept or ICU delivery at home is increasing. This concept is increasing. People are more. There are setups. There are platforms which can provide you to deliver the ICU setup at your own home. So in those things, digital ICU concept comes in handy. And there are various AI-based data integration system software which are being integrated in the tertiary care ICUs more and more. Now, what are the benefits of the digitization? First, there is an improved patient monitoring, and remote monitoring is possible. So it overcomes the geographical barrier and monitor the patients in the remote area. So the cloud ICU concept, that is the first benefit of the digital ICU thing. Patient can be at home, it can be ICU, in the ward, wherever. Like in our hospital, we have a kind of DOSI platform. So this DOSI platform, what it does, it's kind of very tiny software that can be kept beneath the patient's bed, which constantly monitors patients' vital parameters like heart rate, blood pressure, temperature, all these things, even without an external monitor. So those things, and that can be getting fed in a kind of another monitors, which is placed in the sister's desk, and they are remotely monitoring, and that can be fed in the primary doctor's mobile or laptop as well, and they can remotely monitor. So we do not need all the patients to stay in the ICU for monitoring purpose only. Those patients can be monitored even in the ward, sitting with the relatives and all. So those things are a kind of benefit. Thirdly, there is a vital, so the patients can be constantly monitored with these devices and accordingly the treatment plan can be changed. It minimizes the chance of human error, and it remote monitoring system facilitates the monitoring during the transport as well. Like somebody is being transported from some hospital to ICU in the Apollo or somewhere. So during the transport system also, the digital system can integrate and we can communicate with each other. And second benefit, we have a kind of paperless record keeping. It's called EMR. So we have a kind of complex chart that we every day see that the sisters are, most of the sisters' time goes in feeding this pulse rate, blood pressure, urine output, the amount of the fluid that is going inside the patient's body. All this complex chart can be fed in the laptop-based chart. So that can be automated, integrated to the system, like all this heart rate, pulse, blood pressure will be auto-charted in the flow sheet. The data will be taken directly from the patient, from the monitors, from the infusion systems, from the temperature systems and all these things, and they will be fed and they will be monitored. So sisters will spend lesser time in doing the tedious job of charting. They will be auto-calculated. So all this clinical documentation can be done automatically. Second thing, the flow sheets will be automatically charted. The bedsides, the computations of the 24 hours urine output, 24 hours of intake will be done automatically. So all those things will be integrated. Like suppose the physicians give some amount of order, those things will be integrated directly to the pharmacies probably, or to the radiology team, and they will automatically get a feedback. Okay, the order has already been placed. It is their job to give the medicines or do some particular radiological thing. So idea is to doctors or the sisters, they spend more time to the patient's bedside rather than doing an idle documentation, tedious documentation in the bedside. So purpose of the EMR is to enable the healthcare worker to spend quality time on the clinical care, not on documentation, as the patient records from various sources will be available in the e-format in the hospital information system, which I call HIS. And it improves the overall system efficacy. The packs can be integrated in the digital module. The pharmacy can be integrated in the digital module system. The pathology and the microbiology reports can be integrated in the module. The infusion management links the infusion pumps to the patient's chart. Any adverse drug events can be noted. And there is a constant recall. Suppose somebody at the central line, somebody with the invasive lines, those lines, suppose anybody with the line more than 7 days, 8 days, we can set up in the platform. If those time is there, it will give a constant pop-up to remove those lines, whether the line actually needs to be removed or not. So that actually decreases sometimes there are a lot of centers, like we put a central line and then forget in the ward setting, sometimes it happens. And we end up having a collapse. But if you have a kind of system where the doctors every day being reminded to remove the lines, then probably those things can happen more. And there's a digital alarm system which pops up, like any kind of change in fluctuation of the patient's vital parameters, which will pop up. And that pop-up will be kind of, unless we address that patient, the pop-up will not go. So all those things will increase the patient's safety. And all this data can be analyzed and will help in the decision making much and more effectively. Plus, there is a communication. Most of the time, we communicate on WhatsApp. Like there's a very, very effective way. Or we just call. Suppose some incident happened, we call. Suppose there are 3 caregivers in the particular patient's care plan, we call all 3 caregivers. All these things, tedious things, probably sometimes will come down. Suppose everybody is linked to a digital platform. Everybody will get a same pop-up at particular point of time. Any kind of incidents happened. So there are kind of advantages. Home monitoring can be done, post-discharge follow-up can be done. COVID patients, like it has been started with the kind of home monitoring system in the COVID patients. AI in the ICU, now critical care is a data-driven specialty. ICU demands instant processing of the available data and take a decision in a split second, like what we do in the morning round. We see that what happened we just try to analyze what happened in the last 24 hours by looking at the complex chart. Those things, if we can do, if you kind of already integrated data, all this in a software, the software will tell us that probably, okay, for this patient, this number looks abnormal, we need to address those things. So those things becomes more convenient and becomes less stressful. Okay, if there's a less chance of forgetting one thing, looking at one thing, because it's a machine which does automatically all those things. The systems will become more efficient to reduce the human errors. Not only that, an early interpretation of the data through AI helps medical team to pick up subtle warning signs and choose suitable treatment option. And AI can be programmed to trigger appropriate escalation metrics and clinical flow pathway. Next is the scoring, which is very important. Most of the time, how many times we do a SOFA scoring, Apache scoring, somebody comes to the ICU. We do not do most of the time because it is tedious to do. If you have a kind of already integrated data in a system with a digital ICU system, at that point of time, the calculation of all those things becomes very easy. So we can know that we can predict what will be the outcome of the patient. Suppose somebody comes in an Apache of 16 and somebody comes in an Apache of 30. We know that which patient is going to survive, which patient is not going to survive. So prediction to the clinical communication becomes more and more easy. We can calculate the ICU quality indicators like ASMR and all these things. We can actually understand the performance of our ICU, which is how well it is working. Now, what are the challenges in digitalization? First thing, as it has been told, it's a major problem is the data security, because our system is acquiring all the data from the patient, which sometimes if it is hacked, the system is hacked, your entire data is exposed. There's a kind of medical legal consequence. So this is one of the major threat in adapting a digital ICU as a whole. So most of the work is going on to make this platform more and more safe. Second thing is the integration and the compatibility issue. Like always we think, how we integrate in my ICU. So because it requires some amount of some investment to buy those softwares, buy those hardwares, and then place those hardwares in the hospital or in the ICU. So, and it's always a challenge whether we can do it, whether it is possible to do it, how many data it will require, how many costs are involved. So that is always a kind of mental barrier all the time that we have to adapt to this new technology. And we fear, like probably we are more afraid, like when we talk about the machine, this artificial talk about the artificial intelligence, we think that, okay, we'll lose the human touch of the treatment. There's a human touch of the treatment. Like when we talk to a patient, when we touch a patient, we feel that probably, if most of the things, if the machine sees the pupil, if the machine sees the auscultates, all those times that we feel that, okay, probably we'll lose the human touch, which is very much important. But it is not that it is not always the fact. The technology is not at all is a competitor of a human being. It always tries to complement the human efficiency. So that we need to understand. So, and that is why we need to adapt. And if the system makes it more safe and less error prone, at that point of time, it is better to adapt those systems. How do we overcome these barriers? Most of the time, it is training and trying to adapt. First, mentally try to adapt. Mentally try to change ourselves, evolve ourselves, and then we need to constantly train. That has been already been told. Summary. So digital health revolutionized the delivery of the healthcare. It is changing the way in which we diagnose, we treat, manage, and prevent health condition. Digital technology is also a major factor in shifting the focus of the healthcare from healthcare professional to more patient-centric approach. Advancement of the technologies are associated with improved patient monitoring, enhanced data analysis and decision making, and efficient communication and the collaboration. We need to address the concerns such as data security, integration issues, and the need for training and adoption. And the call to action is to prioritize the implementation of the digital solution in the ICU to improve the patient outcome and optimize the healthcare delivery. Thank you. Any questions we can take? Thank you.
Thank you, Dr. Sudeep, for excellent view on his digitization and its integration in critical care. And every now and then we upgrade our gadgets. Why not we upgrade ourselves and use the digitization in our clinical practice? So we thank our chairpersons, Dr. Prachi and Dr. Chetna. I request Dr. Deep Sugandh to felicitate Dr. Chetna. I request Dr. Vaijanti Bhavsar to felicitate Dr. Prachi. I thank chairpersons for sparing their time from their busy schedule. Next, moving on to our next session, I would like to call upon our next chairpersons onto the stage, Dr. Swapnil Khadke. He is the consultant at critical care medicine at Apollo Hospital, Navi, Mumbai, and Dr. Sachin Nalavade. He is a consultant physician and leading practitioner at Panvel. So our next talk is what is an e-ICU. Now we have known already about what is an e-ICU and its benefits in interior areas. To talk on this topic, I would like to call upon stage Dr. Mahendra Bagul. Please welcome.
Any of you who are a IMA Navi Mumbai member, they can go to Fortis Hospital and cast their vote. Today is the election for the Maharashtra State IMA President, so you can go to Fortis Hospital. It is up to 12 p.m. So you can, 12 o'clock, 12 noon. So you can go and cast your vote. Anyone who has not casted a vote, who are the IMA Navi Mumbai member, they can go and cast the vote, because it is always important to cast our vote. That is our moral duty to do it. Thank you.
So now we'll see in detail what is e-ICU and how are its benefits in the remote area, how we do it actually. So let us start with some examples to understand all the things in a proper way, means how the e-ICU works and how it benefits to the patients and how the doctors from the command center, they tell about the patient care. So my first slide is this. Can anybody tell what is going on in this slide? We are all very fond of cricket matches everywhere. And even the World Cup has come now, so it has become a part of our life to book tickets before it comes to know that the World Cup is there. So it same happened in Ahmedabad. When India, the final is there, all the hotels are booked and everything happens. So we are so much fond of the cricket. So in this particular slide, if you see, a single batsman is there, and he's surrounded by so many players, okay, and there is one umpire. When the bowler bowls, what happens, you see? When the bowler bowls, he goes in front of the umpire and he blocks his area to see what is happening there. And the ball hits to the pad. Now you tell me what happened, whether he is out or it is not out. Review, correct. There is a third person sitting to see all these things. The umpire, as you told, he told to see the review, and the review is seen by this man. This is the third umpire. What he'll do, he will use the gadgets. He will use the camera. He will tell them, चलो replay करो, दिखाओ, क्या हुआ, कैसे हुआ, फिर मैं फैसला लेता हूँ. This is the same thing we are doing in the ICU. We are the third empires. We are the silent sitting people where we'll see what is actually happening to the patient. What is the heart rate of the patient? What is the urine output of the patient? How is the patient's rhythm is there? How is the patient saturation is there? It's as simple as that. The state of in the state of Indian ICU, if you see, the demand of the doctors is very high as compared to the supply. The quality issues of ICU are everywhere. Then the accessibility of a critical care intensivist in the remote area is not there. The availability is not there. The ISCCM almost 12,000 members. This is the current data. This 12,000 ISCM members are there who has done their IDCCM or who has done CTCCM. So these are the members total, but still they are less. Okay. And the specialty ICU found everywhere in India in the remote areas are also very less. The all purpose of this is to make a good ICU where the patient care can be taken properly. So more patients, older patients, less doctors, less time, doctors are less, the care of the patient is going down. Because of that, the evaluation of the ICU took place. The ICU design, if you see, can we have a safe ICU? Yes. Everybody wants their ICU to be safe. The person anybody who is practicing alone, he wants his ICU to be safe, a place where everything is taken care of his patient. Means he doesn't want the headache. He wants that if the patient is sick, the patient blood pressure is low, somebody should tell that you give fluid. If the blood pressure is low, somebody should tell them to add NORAD. Vasopressor, if there is a rhythm change, somebody should analyze the rhythm and tell that give Cordron or give shock or whatever the things are there. So everybody wants a luxury life. So this luxury of thinking of luxury along with the best care of the patient will make the ICU safe. Okay, so what is required for the safe ICU? First is shape, isolation, emergency response, infection control and assess. So we as an Apollo team, our initiative of the future to make a good ICU is here. So the leader in telemedicine, the natural move into the tele-intensive care, advanced stage and design of implementation of tele-ICU, vision from our top management, especially our chairman, Dr. Pratap Reddy sir. So the critical care team of the future. So it is showing like robotic and hand with the human. It is nothing but the use of the gadgets and technology to take care of the patient. You have know that now artificial intelligence has becoming a part of life everywhere. If you see the Zomato, Swiggy, they are just every time the message is popping up like this. Last Thursday you have ordered burger. Now this Saturday, why not? Again, they are popping up like this. So as the digitalization about Dr. Sudhir Sen also told, there will come, the patient has got a fluid of 2 liters and you told to give furosemide. At that time, are you again want to give that one? So the digitalization and everything is taking hand in hand for the betterment and the care of the patient. So electronic ICU, if you define it, it is an intensive care unit, is a form of telemedicine that uses the state and art of technology to provide additional layer of critical care, and e-ICU may also be referred as a tele-ICU. It is an audio-visual communication and computer system that links critical care physician and nurses to intensive care units in the remote hospitals. The objectives are to understand the real-life role of tele-ICU in the modern ICU, go through the common case scenarios. These are my objectives now. Now I will show one by one all of these things, and to demonstrate through a video how the Apollo Tele-ICU team functions. Then discuss how is the service can become a reality for the audience. Tele-ICU as a solution for safety. Electronic monitoring of the patient will help ensure safety and quality. Autopilot in a planes and feedback loops in the background. Likewise, tele-ICU in the background is there. The solution for India needs to be realistic and designed for the unique environment here. Simple and customized solutions are responsible. So when we travel through the plane, how many of we know that this is the pilot and you are safe that, no, this pilot is there, I am 100% safe, there will be landing will be there. So no tension, nothing. Now the plane has started, plane had taken off, I'll sleep now because Salman Khan is taking off the pilot. We are knowing that. How many of you know that? We don't know. But 99 point of the time, 99%, there will be safe landing. Like this only, when the patient is sick, there is someone is there to take care of them. That is the e-ICU doctors will be there. So this is some concept the same like that. So there is a loop of, there will, in the plane, how will be there? There will be a loop of discussion will be there. They will know how to take the plane, where to take the plane, the direction they will know. The same way, there will be intensives will be guiding to the doctors there, what to be done for their patient. How can e-ICU help to remote e-ICU? We can take daily rounds, as I told you already. Case discussions can be done. Whatever the case they have, we can have a discussions with the RMO, sisters, nurses, or who's the doctor present there. A protocol-based treatment can be told to them. Then pooling problems and sharing solutions can be done. Whatever the other problems they are facing, technical glitches, that can be shared and the solutions to that can be found out. Then continuous monitoring, we do it by the e-ICU. Supervising procedures, we supervise all the procedures. If somebody want to put a central line, we tell them, just you be where, if you are putting a central line, just inform us. We tell them how to do it in a very aseptic manner. Then assisting in referring to specialist consultation by three-way, by voice and video technology, and training the ICU team. Whenever, if they require a specialist opinion, neuro, if they want a radiologist opinion, gynec opinion, any specialist opinion, we direct them to them. Okay, so we help in that also for taking the consultations. Now, real situations, if you see, if a patient have a collapsed lung, it can be recognized by seeing the X-ray. In the tele-ICU, we get the X-ray in the morning, we see the X-ray, and if any pathology is there, we tell them. Then low blood pressure, as I told you, beat-to-beat monitoring is there, where we see heart rate, we see the pulse, we see the SpO2, we see the blood pressure. So that will help to know what is the problem in the patient. Then complex breathing problems can be solved. Sepsis and blood infection can be managed rapidly as per the protocol. And this will help to avoid the transfer of the patients. See, the more the time the patient is staying at the remote area, what will happen, if the patient is staying for the more time, and if he is getting a better care, and if the patient is becoming better, what will happen? This will help in two things to the hospital. It will increase the remuneration of that particular hospital. Second, it will give a good impression to the other patients or other people staying nearby that the patient has become fine here. Okay, so this will be helpful in that manner also. Then recognizing acute myocardial infarction and telling them the treatment and ventilator management. If the patient is having ARDS, we can help them to tell the ventilator strategies as per the protocol. Then low and high sugars can be managed. Advanced critical care expertise can be shared with them. What are the clinical alerts we get in this e-ICU model? These are just the low and high blood pressure. As I told you, beat-to-beat monitoring, in that we get it. Slow, fast heart rate, low oxygen, if it is there, we get the alarms for that. Abnormal trends in urine production, we know that. Then abnormal labs and abnormal ECG. These are all the alerts we get in the e-ICU on the screen, and with that it will helpful to tell them and guide them for the treatment. The e-ICS, the command center is there, and from the command center we take the all the lab data, a summary of the patients, we make it, we see the vital trends, imaging, alarms, e-task, and the cart is there, smoke center, 24/7 consult coverage is there, seniors and register. This is already told by everyone to you. So I'll just keep these evidences as in next talk, Dr. Divya will be telling that one. These are also some of the evidences, that is Rosenfield and et al., the Coyle and et al. These are showing that the mortality, length of stay, and the cost, it all decreased with the help of the e-ICU. Now set of real scenarios, if you see, if a 50-year-old male with acute chest pain since 1 hour with radiation to left arm, past history of high cholesterol and hypertension, tele-ICU input is requested. So this is the scenario that is happening in the remote area, and they have forwarded this summary to us. Now what we'll do in this one? We'll see that. What is the next? As an expert, what we'll do? How could the tele-ICU will help in such cases? Immediately we'll tell them to view for the ECG for confirming the diagnosis. Okay, and set up whatever lab tests we can tell them. Coordinate for the thrombolysis, or we can help them to activate the labs. Okay, may are able to coordinate to transfer to a location. If the cath lab is not available at their place, we can tell them and coordinate to shift to a cath lab where it is required, and ensure stability of the blood pressure, arrhythmias, and while the patient is awaiting the transfer, and manage cardiac arrest and initiate therapeutic hypothermia if at all it is needed. So this is one of the example where if such a kind of patient comes because of the 24/7 coverage, we can really help the patient there. Patient 2, 60-year-old woman with a severe shortness of breath for 4 hours, prior history of asthma, poorly controlled with nebulized medication, presented to ER, placed on NIV, had a cardiac arrest 3 times, resuscitated and shifted to ICU. On arrival in the ICU, blood pressure was 80 systolic on high dose of vasopressor. On examination, decreased breath sounds on the right side. Chest X-ray was requested. e-ICU consultation was initiated from their side. So this is the second scenario. A lady with a breathlessness, shortness of breath, after giving nebulization, resuscitated. She had an arrest. So what next? The diagnosis and management for such patients can be done. So in such patients, we instantly offer support at the bedside. Okay, bedside team may be nurse or the doctor on the way. Chest X-ray is viewed, ventilator settings are viewed in such cases. We supervise emergency procedures if center line, art line, anything required. Then we coordinate calling specialist if required in such cases, and document whatever the clinical progress is there for the same patient. So life is all about choices every day. The choices shape our destiny. So if you want to shape our destiny, I think e-ICU is one of the things that will help to make a stressless life. So medico-legal aspect. So this is one of the point that has been, means what we can say is not clear or not, we are thinking that it is not clear in the terms what are happening. The thing is that what I came to know recently in this, the government of India given a tele-ICU guidelines in March 2020. If you just Google it, tele-ICU guidelines of government of India, you'll find it, the tele-ICU guidelines are 25th March 2020. When the COVID, at the time of the COVID, immediately, I tell you, on 22nd of March, there was a shutdown, 2020, and 25th, government of India has given a guidelines for tele-ICU. You can just Google it and you can see. So the tele-ICU is very helpful. So the guidelines are very clear from the government of India. You can use it. Registered medical practitioners can give, is authorized to give all his inputs for the patient by video. Okay, audio and video, both, but not by telephonic. They have told that don't give telephonically. By audio, video, we can do it. And this is audio, and our setup of e-ICU is an audio and video. Okay. This is our unit of this e-ICU unit of Apollo, Navi Mumbai. We can just have a look of this. One of the thing of medical legal aspect I want to tell you. In this, what happens, it is told by the government of India. Whatever we give advice to them, we are liable for that. If I tell to give any patient any antiarrhythmic or any vasopressor or that, for the procedures, see the procedures are done on that side. An expertise person has to be kept for the procedure. So during the complication of the procedure, anything happens or other things happens, that is the other part of story. So what are the expertise inputs we are giving, we are liable for that. So it, in the same way it comes, both are liable for the things, whatever is done for the benefit of the patient. So it is ultimate, we have to make the patient benefit from whatever expertise inputs we are getting and whatever the things are done from the other side. Okay. So thank you very much. If any questions are there, please let me know.
Thank you, Dr. Mahendra, for simplifying the functioning of e-ICU by your examples. Now, moving on to our next topic, what is an e-ICU and efficiency and impactful deliverables? In any project, deliverables play a significant impact on the overall success of a project. They serve as a tangible evidence of the project's progress and achievement of its objectives. To highlight on this topic, I would like to call upon Dr. Divya Ved. She's a consultant critical care medicine at Apollo Hospital, Navi, Mumbai. Please, ma'am.
Thank you, everyone, and good afternoon to everybody, chairpersons. So since morning, we have been hearing a lot about e-ICU, what is the technology, and how can we adopt it to improve patient outcomes. What I will be taking a very short time to speak about is how, what is the evidence that this technology actually has an impact on the outcomes, and how do we assess the efficiency of such a system. So as we know that intensivist staffing, it is very well known now that intensivist staffing is inversely proportional to any hospital mortality. So there is a group called as the Leapfrog Group Recommendations. This is a non-profit organization that is dedicated to improving healthcare quality. And they have come up with certain recommendations for improving the quality of healthcare all over. So their recommendations states that the mortality rates are significantly lower in any ICU which is managed exclusively by board-certified intensivists. There are other research also which shows that intensivists, whenever there is an ICU which is managed or co-managed entirely by an intensivist, there is a 30% reduction in hospital mortality and a 40% overall reduction in mortality. So as we know that in our country, there is a huge shortage of intensivists, particularly in rural areas. And also in urban areas, there is a deficiency if you see that proper trained, experienced intensivists are always less. So in that situation, a tele-ICU becomes a very good model for providing real-time monitoring of patients' instabilities or any abnormalities in laboratory values, ordering diagnostic tests, making the diagnosis, ordering initial treatment, even implementing any intervention through controlling life support devices. So definitely it becomes a good technological advance that will help to improve the quality of critical care, also increase the productivity of intensivists. So how do we assess the efficiency of such a system? The efficiency of any tele-ICU depends on certain parameters. One thing is the clinical process. So the outcomes, whatever is related to service delivery, like an attendance or an adherence to the programs and the recommendations of the programs. We can assess certain clinical parameters like mortality rates or length of hospital stay, which can also indirectly tell us about the efficiency. The healthcare provider as well as the staff satisfaction with the program. It is very important for the clinicians to understand and accept the program to have a better clinical as well as a financial outcome. The healthcare utilization. So there may be some events which are outside the scope of the program also that we can influence. For example, decreasing or increasing the admissions, hospitalizations, ICU admissions, and also it can have an impact on the average length of stay. The cost associated with any system becomes a very important factor of how well we can implement, how well we can provide. So cost from the patient's point of view as well as organization point of view, there will be various costs that are implied. And what is the revenue that we will be able to generate with such a system? So what are the impact that happens on the patient outcomes? So any tele-ICU system, there are various interventions that can be done. The intervention can be anything from a clinical monitoring of the physiological trends. It can be looking at laboratory values. It can be doing some interventions, virtual rounds. But it is very important that the timely and faster response time that impacts the overall outcomes. Compliance with best practices. So this is something that has a lot of evidence associated with it because there is a lot of disparity when it comes to adherence to quality bundles. Like for example, the care bundles for VAP or DVT prophylaxis, sepsis management, or even compliance with lung protective strategies. So these compliances with these strategies may not be there uniformly across all centers. And this ultimately has a big influence on the overall outcome. So with tele-ICU, what you have is you have an expert who can provide this compliance with these quality improving bundles. So that will have, there is a lot of evidence that says that this will actually improve the patient outcomes. And coming to the patient level outcomes, there is an impact on hospital length of stay, there is an impact on mortality that we will see with various studies. So this was one of the earlier tele-ICU when it started in the United States, that is WIS-ICU. That was the original one which started in 2004. So they also showed in their data that there was a lower hospital mortality, 27%, And the length of stay also decreased from 4.35 to 3.63. The average daily cost was also reduced by 25%, and the hospital revenues were higher. So the authors in this concluded very positively about the association with lower mortality and improved cost. Subsequently, the different studies, there were a lot of heterogeneous results also, because the technology that was used was different. But there was a Navi report which showed that it was not uniform. Replicated improvements was not seen in all studies that was seen with the initial study. But there have been various reports, like you can see this, the Leh Valley healthcare system mortality reduced from 15 to 10%. The Sutter health system did not show any changes in mortality, whereas the Cornell Medical Center showed a decrease in mortality 15%. And the Zavada study showed an improved mortality as well as a length of stay. So in this, there are various studies from 2000 to 2004, which you can see as there is an improved mortality rate, reduction in the overall length of stays in the ICU. The last study which is showing, which shows that there is actually mortality reduced from 40 to 18.86%, and total they also estimated the number of lives that were saved over a 30-month period. And in the earlier, the study which was done in 2006 in Parkview Hospital, they showed that the cardiac arrest declined from 9 months prior average 38% to 28%. So they were even able to document the amount of cardiac arrest episodes that reduced. So various studies from 2004, 2007 have shown an improved outcome. So this one study which was done by Rinken et al. In Sutter Hospital, Sacramento, they actually showed an accurate sepsis identification was achieved through the e-ICU. There was an improved sepsis bundle compliance and also reduced mortality with the use of e-ICU. So thus the important questions now is, does the tele-ICU implementation actually improve the ICU performance? And if it does, is this benefit, we are able to maintain it longitudinally over a period of time? And actually, does the expertise of the telephysician affect the ICU performance? And does it actually reduce the workload of the on-site physicians? So it is very difficult to exactly give an exact answer to all these questions, because it is difficult to assess some of these parameters. So there are various studies which have used some surrogates to assess whether we are able to achieve that. So this is one study which was done recently, observational study. This was done in Japan in March of 2023. So in which they have actually analyzed, they have seen pre-tele-ICU and post-tele-ICU. They have observed around 893 patients retrospectively pre-tele-ICU, and then they have taken data post-tele-ICU implementation for a period of 2 years. And they have compared some of these parameters. So this is a single center historical comparison in which the impact of tele-ICU on ICU performance and also in the workload of the on-site staff was seen. So what they have done is the patient's background, the ICU hospital mortality, length of stay, before and after implementing this tele-ICU, they have studied to check what is the clinical efficiency of the program. So staff workload, how they have defined it is difficult to, it is a very subjective thing. So what they have seen is whatever was the physician's frequency and duration of using the electronic medical record, that they have taken as a surrogate to see how much is the staff workload and how much it has been impacted after the tele-ICU was implemented. So what this is the different caseload, different ICUs that were managed, and the staffing of the tele-ICU, as you can see, there was a clerk, there was an intensivist, which was during the daytime mostly, and nighttime on demand, and there was a nurse that was 24/7. So what all daily tasks the tele-ICU has performed, one thing is communication with the on-site staff, proactively using high risk or monitoring the physiologically worsening patients, also venous thrombus prophylaxis, stress ulcer prophylaxis, the medication doses appropriateness was checked, recommendations were given for earlier mobilization, earlier enteral feeding, sepsis management, and most importantly, the ventilator rounds and bed transfer in case the patient needed to be transferred somewhere else. So all this information was used, patient information, the vital signs, the laboratory data, and also various assessment scores that we routinely use in the ICU, like the GCS, the RAS, the CAM ICU scoring. And all treatment information, all devices, monitoring information was all integrated for the clinical decision making. So what they found is that overall, what improvement in ICU performance they could find is that the total number of patients, the number of intubations needed, the duration of patients on mechanical ventilation, the number of deaths, mortality, length of stay, everything was compared. They used the Apache 4 scoring at admission for all patients that was calculated, and this they have used to see what was the severity of the admission. So mortality they have calculated as per the predicted value of mortality. This predicted value was calculated on admission based on this Apache 4 score. So accordingly, they divided these patients into three groups. One was the low risk group, the medium risk group, and the high risk group. So low risk group was predicted mortality less than 10%, then 10 to 50%, and more than 50%. So this is what they found in the difference in the performance of the ICU before tele-ICU and after tele-ICU. So as you can see, the predicted mortality, the actual ICU mortality came down from 8.5 to 3.8. And the hospital the length of stay, overall length of stay came down from 1.62 to 1.02. So this was in the different groups, the predicted mortality, how they distributed according to low risk, medium risk, and high risk groups. For all the separate groups, they have assessed what was the improvement in, what was the change in mortality, and what was the change in length of stay. So what they have found in this is that in the low risk group, the actual length of stay was actually shortened, but there was no change in the mortality. In the medium and high risk group, both the hospital and ICU mortality improved. And the length of stay became longer in the patients in the high-risk group. That could be possibly because the sicker patients, once they survived, they needed more time in the ICU. And this improvement they have observed they evaluated the ICU performance over a period of 2 years. So over a period of 2 years, what you can see in this graph is that over a period of time, one is that the patients became more sicker. There were more sicker patients admitted. So requirement for ventilator was more. The predicted mortality as expected for such patients was more because they were more sicker. But if you see the graph, the overall actual mortality remained the same. So as the patients became more sicker and the predicted mortality was same, but after implementation of the tele-ICU, the actual mortality remained the same. So that was an overall improvement. So does the expertise of the physician actually affect this performance? That they have seen that the number of patients who are mechanically ventilated have increased longitudinally over a period of 2 years after the tele-ICU system was installed. So, and the mortality is unchanged or reduced. So what it means that more patients were sicker, they were mechanically ventilated, and this mechanical ventilation related issues was the most frequent topic that was consulted with the tele-ICU physicians. So the details in respiratory management consultations like ventilatory settings or sedatives or even related to rehabilitation probably. So the overall benefit mostly happens due to the improvement in ventilator parameters for these patients. So the expertise of the tele-ICU physician, which is better in terms of or more experienced or more qualified in terms of respiratory management or ventilator management, did actually contribute to the improvement in the performance. This coming to the workload of the on-site physicians, they analyzed the data of how long they were logging into the electronic medical records to see what is the difference in the workload. So what they found over a period of 2 years, there was a 25% decrease in the number of hours they were logging in. So they concluded that there was a 25% decrease in the workload of the on-site physicians after tele-ICU. So overall, what was found is there is a favorable impact on hospital mortality with sustained efforts. The positive effect was mostly on the performance of mechanically ventilated patients. The workload of on-site physicians definitely decreased significantly. There was more work sharing between the tele-ICU and on-site staff. And this could be this could be a solution to all the problems that we face because of shortage of intensivists. Lastly, coming to the cost, there is always a cost involved whenever we are adopting any new technology. There is a cost of installation, there is going to be a cost with operations and maintenance. So the hardware, software, training, compatibility issues, all that is going to result in cost. So the net present value payback period is what we use to indicate what is the return on investment. And return on investment is mostly calculated mostly based on some clinical outcome parameters, improved outcome, length of stay is what actually contributes to the return on investment. So various studies have shown that there is a improved decreased ICU cost between 25 to 31%, and overall hospital cost reduction has also been demonstrated in various things. So to conclude, we know that there is a big disparity in what intensive care practices, best care practices can be provided in rural areas, and even in urban areas there is a lot of disparity. Now every patient deserves or has a right to access to better care practices. So coming to that, the tele-ICU would be a very better option to provide all these factors in rural areas as well as in urban areas. Thank you. Any questions?
Thank you, ma'am, for making us understand this difficult topic. So I'd like to thank now our chairpersons for their valuable time, and I request Dr. Dulera to felicitate Dr. Swapnil.
Hello and namaste. It's a
Next, I request Dr. Neeraj Mahajan to felicitate Dr. Sachin Nalavade.
pleasure.
I hope till now you might have understood about the functioning of e-ICU, the basic infrastructure needed, the challenges faced, and the road ahead. So before concluding the session, we have a panel discussion coming up. I would like to hand over the session to Dr. Akshay Chalani to moderate the session.
Before we start this panel discussion, actually for this, our Joint Medical Director, Dr. Preeta Reddy, was supposed to come and inaugurate the session for e-ICU and all that. But because of some technical issue and medical emergency, she couldn't turn up today. So, but she was kind enough to send us this video message and clip. So just hold on for the next 5 to 6 minutes. I'll just play the video before we start this panel discussion.
Hello and namaste. It's a pleasure for me to speak to all of you today on something which I think is so important, and that is healthcare. India's healthcare has over the last few decades enhanced considerably. We're capable of doing anything that's being done anywhere in the world. We have reached out with insurance, with high-end infrastructure, with skilled-trained personnel, good nurses, and many, many other equipment and process improvements so that everybody is delivering a much higher standard of care. And India is beginning to become known as the medical value travel hub of the world. And yet all of us as healthcare administrators and healthcare providers, over the last 40 years, we've done our best at Apollo to raise the standards, to bring quality, to share our quality capabilities, and to partner and network as much as we can. I'm extremely happy today to be able to present to all of you a new platform, a new strategy, and a very exciting opportunity to collaborate and connect. It's called Apollo Connect. The ideology behind Apollo Connect is that if we, together as a healthcare ecosystem, are more connected, We can share expertise, be able to give patients a seamless care, move them to higher end care wherever they need, but then also treat them in hospitals and nursing homes all over the country with the best possible clinical expertise available if the local hospital wants it in a flash of a second, because it's an online connected platform all the time. Apollo Connect also has many other features under its vision, whether it's in helping you solve problems on access to materials, the best equipment to buy, manpower solutioning, ratios, quality protocols, education, training. But the most important one is the ability to get a second opinion and to literally have a partner in patient care. On the e-ICU, which is another deep solutioning, very often we all know that, we go home in the evenings, but we're worried about our patients. Imagine how wonderful it would be to have a continuous 24/7 oversight or access, so that when you leave your hospital or nursing home, there is someone within who can connect to a team of critical care specialists who's available round the clock 24/7. It's ideas like this which are born out of our practical experience over the last 40 years in India, out of our commitment to serve the people, and our very firm ideology that hospitals and nursing homes are our partners. General practitioners are our partners, and we have always supported them and worked with them. And I thank you for the support and the trust that you have shared with us. So together, let's connect. Let's create a better healthcare ecosystem so that our patients are safer and happier. Also, use our collective knowledge so that you are able to gain more revenue, have better peace of mind, more process enhancement and improvement and optimization. These are some thoughts that I wanted to share with all of you today. Good luck in your journey towards bringing better healthcare to our country. Thank you for your partnership over the years and for helping us not only become one of Asia's largest healthcare networks, but also, most importantly, one of Asia's most trusted healthcare brands, who is trusted by doctors to treat their families as well as to send their patients when they're critical. It's an exciting world out there. I want to say one last thing, and that is that artificial intelligence is changing the way we do things. The pace of change, the way things, new processes are coming, whether it's augmented reality, 3D printing, and definitely AI, all these are changing the way healthcare is accessed, the way the customer is looking at healthcare, and the way doctors can access the best and the latest treatments and modalities. So as we are on our journey to AI, we're extremely happy to share with you our clinical intelligence engine, so that a doctor who's just come into healthcare or has 10 years experience can practice at an optimal level of care, because advanced diagnostic pathways have been culled and put into this AI engine. With our experience, over 15 million patient records have been used, and this platform has been validated across many global universities and partners, including MIT. So this clinical intelligence engine and many other such advancements are part of the Apollo Connect program, and we are enthusiastic and excited to share with you, partner with you, to connect with you. Thank you so much, and namaste. Hello and namaste. It's a pleasure for me to speak to all.
Before we break for lunch, actually, we'll have a panel discussion. For that, may I request Dr. Amol Kotekar to come on the dais, please. He's a professor of anesthesia and critical care medicine at Tata Hospital. Dr. Manoj, who is an executive committee member of ISCCM, Dr. Gunade, Dr. Suhadeep, and Dr. Divya. Can I request you to just be on the stage, please? At any point of time, any delegate has any question, they can ask actually. So my first question, Dr. Suhadeep, you told about human touch. So it is possible that as we move forward, and improve in this era of e-ICU or technology, is it possible that we are losing the human touch? What I mean to say that bedside examination, clinical examination, you auscultate the patient, you check the pulse, you check the peripheries, you check the heartbeats and all that. Whether we are going to lose this and whether it will impact the future medicine.
Thank you, Dr. Akshay, for asking this question. It's very relevant. Hello. This is very relevant question. Probably most of us fear in the way that and most of the doctors feel, okay, if you lose the human touch, probably how the patient will feel. Sometimes it's a worry to the patient himself. Suppose we become a patient and we need to see a doctor. We don't want to go to a computer. Most of the time, so few days back, we were asking with one of my neighbors, just asked him whether they know about that there a kind of discussion being happening on this online consultations versus real consultations. So the concern do exist, whether the people prefers online consultation more or somebody prefers a kind of physical consultations. Still people prefers the physical consultation, which is relevant and pertinent, and everybody, if you talk about ourselves, prefer to go to a doctor and physically get examined. But here we're talking with a kind of platform which is not a substitute of the physical examinations or something like that. It's a complement to the physical examinations, to make the system more error-free, make the system more safe to the patient. Somebody staying in the hospital, staying in the ICU, getting monitored on the time. It's an advantage. It's an added advantage. Most of the time, what is the key difference between the ICU and ward setting? The ICU is a better monitored. As it is a better monitored place, we can take care of a certain particular things much more quickly. Otherwise, the ward probably it is a less well monitored. If we adapt to a system, probably whether in the ward setting also it becomes monitored, in a way we can take actions faster, more quickly, in a way that it will make the system more efficient. It will make the system more patient friendly. So in no way we are competing with the doctors, the physical examination. It's a kind of to complement the entire system, how the digital things or the tele-ICU concept, all these things will help. So I think that hopes some of the answers. So still a lot of concerns, but probably if we can adapt to the system, and then it's a changing reality. Ultimately, it's a changing reality. The technology has always helped mankind to progress. It has never regressed the mankind. Initially, when automation came, there's an hindrance. Okay, whether automation will be a kind of obstacle in the progression or not. So ultimately, it actually helped. So probably it is better we adapt to our new situations more and more. So it becomes easier.
Yeah, that's true, doctor. So basically, it will just complement. And Dr. Amol Kotekar, my question: you work in oncosurgery department, Tata Hospital, which is very heavily occupied with the patient. So whether this role of e-ICU in remote places, not only, I'm not talking about the surgery, but in diagnosing the things. And now you know that they are starting the satellite center in Kharghar or in remote places. So how this e-ICU will play a role, mostly in the context of malignancy, oncology patients, where we can do faster diagnosis, or sitting here from Tata Hospital, Parel, you can manage the patient in remote area like Bihar, Jharkhand, Uttarakhand. Whether this technology will help, and in case, in addition to diagnosis, whether it will future in after 5 or 6 years, whether it can help from here surgeons to tell the surgeons who are at the bedside or at the remote places to follow this technique or that technique. It's like tomorrow board meeting. At the end of the day, suppose you are not very sure, suppose you just take an example of see a breast or see a prostate. So first you do a radiology, first you do a chemotherapy, first you do androgen therapy. In this context, whether this e-ICU role, whether it has any, it will play any role in this better outcome of the patient, at least decision making for the oncologist or oncosurgeon. This is my question to you.
Yeah, certainly. So we have many centers in remote places, as you said, like we have a center in Assam, we have a center in interior of Bihar, and all these centers are not fully, so they are getting staff. So some centers are in making, some centers are, not all people are on the board. Certainly this kind of technology where you can get, you don't have to travel all the way to that center, and all the team doesn't need to travel to the center, but the patient will be connected to any hospital where we have all the doctors on board, or 2-3 doctors at different center will be clubbing together with this technology and giving opinions. Certainly it's going to be helpful.
Yeah, that's true actually. So whenever you are in doubt, you have a second opinion through this e-ICU, you can just take a call. Dr. Divya, you showed 1 or 2 slides that the duration of mechanical ventilation slightly increased in the patients who were managed by the e-ICU. So my question, whether this too much of expert will increase the cost, that is one thing. And second, too much of involvement of too much people, e-ICU and the bedside person, whether it will sometimes can extend the cost, add the cost which is not required.
No, if the mechanically ventilated patients, they receive proper expert advice, then overall if the outcome of those patients is better, then that will actually contribute to the cost going down. That is what has been shown in different studies. The reason the cost goes down is because the outcomes are better, the length of stay is shorter.
Yeah, so Dr. Gunadhar, my question, when we talk about the digitalization, it's other than Apple and all that, it's very easy to get your data. So even if you take a simple laptop or any software, there is always chance that somebody will hack that. So in this is question basically, suppose some other hospital or computer people hacked your, is there any chance or whether there is a possibility that your computer or somebody will hack the data? Or coming back to the privacy, sometimes now suppose you are managing the e-ICU, the system is not working, so then you transfer the data through the WhatsApp and all that. So what are these medical legal implications might come across, or whether you have seen some incidents, then suppose the e-ICU is not working, the machine is not working, immediately we need to see the ECG. So whether transferring the data from one patient to another through the WhatsApp, when we don't have a consent, whether how it will work actually. Can you just throw some light on that?
Yeah, so actually that is a concern. You are absolutely justified. So now with the growing age of technology, I think we have to more focus on safety and you can say the security for the data. Now data is, you can say, the new gold, as already told by many of the technology persons. So I am sure going ahead further, there should be more and more security or one-to-one encryption to be coded in such kind of data. But simultaneously, it is the one of the ethical and moral responsibility of the command centers of the hospital, who is taking the responsibility of the the different peripheral hospitals to be get connected to protect their data. And of course, there are a lot of laws, or there are a lot of medical legal aspects who are being coming up for the breach of security or breach of the data concern. But it is actually the doctors, you can say the command center specialist or the leader who is involved in this, to have the ethical and moral responsibility to protect the data of every individual and every hospitals. The leakage of data is, of course, sometimes it may be possible, but I am sure going ahead further, there will be a lot of newer security systems. Like you have to upgrade your antivirus capacity every yearly. You have to keep on checking your software systems regularly. The maintenance is very important. And the most important part is 24/7 good IT support and IT backup. So that is the essence of the time. So now more and more the focus is towards changing technology, and I'm sure that in going ahead further days, like how Apple has developed its own security system, there are a lot of security systems are coming off to this field, like the quantum computing, the AI-enabled security system and safety, the machine learning platforms. So where the data is absolutely 99% safe. So I think that concern will not be there after 5 years or going ahead further.
Yeah, basically in addition to managing the patient, you need to manage your IT department also, so that at least you are legally and ethically safe. Dr. Manoj, you were there from the day one when we started actually. So what are the most common difficulties generally we face? Because right now we are on the learning curve, we are on the path, we are still learning, still treating. So initially few days we have some hiccups about the when we start the e-ICU and all that. So what are the most common challenges generally we face as a bedside, because you are working suppose at both the places, bedside and the in front of the camera.
Basis, we face the challenges of the staff. They need to be trained in the technological advances, how to use the, how to guide them, give the proper information about the patient, uploading the investigations, parameters, X-rays and everything, and updating about the patient. The RMO should update a case properly to the command center so that they can take a proper decision about what to do next. And the main issue is the training of the ICU staff. The nurses are not that technically trained, and in the remote areas there is lack of training in the critical care as well. So we need to train the staff and doctors at the remote areas as well. Though at the command center they are all experts available, they are very well trained, but the remote areas that's not the situation.
Yeah, coming to the same question, can you just comment on that? Whether it will make that center little in the comfort zone or lazy actually, because they know that somebody is watching, so they are not, I'm not saying this, but whether the system will become more casual at that bedside where this is, anyone can answer.
No, actually, anyway, both should be very vigilant. That's what we have to do. We have to monitor the patient continuously, and at the bedside, the monitoring will be more better. So the staff should be monitoring it closely, and at the command center also they should be very vigilant that sometimes there are some arrhythmias and all those things. The bedside nurses may not be knowing that arrhythmias, they cannot pick those things. But at the command center, we will have alarms and technological things, so we can pick up those things and we can timely advise the treatment.
Yeah. So another, any of the panels, basically the major challenge here that whatever data you get from the periphery actually. So now suppose going ahead in the periphery you want to run the e-ICU and all that. So as we know in India there is a lot of disparity between the qualified intensivist doctor and the number of patients. So whether with this technology, already Dr. Amol, my question to you, whether we can train the staff by sitting here, what I meant to say, suppose how to do a CPR, how to do a ECPR, or how to do mechanical ventilation, intubation, by sitting here with this technology, is it possible to train the staff in the remote places actually? Basic like BLS or ACLS, though we know that during the COVID time, this American Heart Association, what they have done that even if on the virtual mode, they have seen whether the patient is doing, or the person is doing performing this ACLS properly or BCLS not. So on the basis of that, because of this COVID, they certify some fellows that they are BLS trained, they are given the AHA card. So going ahead, my question to you, or anybody can comment, whether this will improve the basic skills in the remote area where there is no access to the medical facilities or infrastructure. From sitting here, you can train them for BLS and ACLS, and in case if it is there, how effective would be, or whether it is premature to talk about that, or it is a long way to go.
That's very valid question, Dr. Akshay. So certainly because of COVID, we were forced to use this technology where we are teaching the staff or we are managing patients remotely. But of course, there are some points where you that needs a hands-on supervision training, and that cannot be replaced by any e-training or a virtual training as of now. So obviously you can give some lectures online to remote places, but when it comes to the actual assessment of skills, I guess the real time when sessions are better than the electronic sessions. But certainly in few years maybe we'll have some more technological advance where we can actually assess the skills. Like for example, we have a CPR training modules in our hospital, where the mannequins tells us whether the compressions are good, whether they are adequate, what is the rate, and this is connected via Bluetooth to the mobile. So same thing we can be done at a remote place, but of course we have to send the mannequins to a place and they will do CPR, and then from a remote place we can assess and tell whether the CPR quality is good or not. So certainly it's a way forward.
Yeah. So yeah, that's true, Dr. Gunadhar. My question, whether those who are here, I just want to tell you, Dr. Gunadhar is doing, in addition to critical care, he's doing business administration also, diploma in business administration. So my questions are more like that to him. My question in the over, Suppose everything goes well, whether there is a side effect of this, whether the corporate hospital will try to send us home, what I mean to say, whether it will decrease, it will affect the physical empanelment of the doctors, or they are more technology driven, they will say now 2 are enough, rest 3 you go home. Whether, this is my question to you, whether this might affect the, not our employment, but whether it will affect the manpower physically recruited at the hospital. That is very gray zone questions.
Yeah, absolutely, but I don't think. So basically, I think it will create more and more job responsibility, and it will create more and more requirement for different fields. Like now, everything is become specialized. So the person who is now going into the this remote access healthcare system, so he is not replaceable by the technology, or he is not replaceable by the person who is working on site or who is working in a physical environment like in the ICU. So both are basically the complementary. So the person who is sitting on a e-ICU platform, he has to need the input from the doctors across the remote access locations, so that he can improve his own opinion and improve his own outcome. So the problem comes when we don't master the technology, or when we don't adapt the technology and we don't know how to use the technology in a better way. It is not the other way around. So technology is always there to help us and to improve our measurable outcomes and the clinical input and the clinical improvement. So whether it is a finance, whether it is an IT, now there are a lot of messages are going on different social media platforms, like either you learn ChatGPT, either you learn this or you will be replaceable. This will kill your 10,000 jobs or millions of jobs. So it is not like that way. So technology are there since years. Like when there is a boom in 2000, when the new internet came, a lot of people thought that there might be a recession and people will lose their job. But now you see the IT industry growing at a rate of 30 to 40% per year. The finance industry is growing, the healthcare industry is growing. So that is why this technology will also keep on growing. So it is the person or the choice. Choice depends on us, whether we want to master it and we want to use it in a proper way, ethical way, or we want to perish. That is the question here. So it is both are complementary. So every segment, every sector, it is basically complementary, and it will definitely push or boost the system to have a good measurable outcome, and that is why the growth story of India is the continuing in every field. That is the reason.
Yeah, that's true. Basically, it's for both sides it works. Dr. Sudip, my question now. Last few days back, I visited this Bangalore, where they are running this cloud physician actually. So from last 5 to 6 years, those are very trained in US board certified critical care physician. But from last 5 years, they are just sitting in front of the laptop. They are sitting. So my question, over the period of time, suppose we wish to manage this physical ICU also and the e-ICU. So whether it makes sense to just do some physical duty, what I mean to say, not only for the staff, nursing staff, years together just sitting just on the laptop. So you rotate them through this e-ICU, then physical ICU, the same thing whether it applies to the doctors, because few are dedicated to only this e-ICU. So whether you will lose this clinical touch to this patient, or to going ahead, whether we should do sometime 6 months this, 6 months that, or whether we need to continue and take it as when it comes.
Yes, so that makes sense actually. Like, so it's a kind of lot of my friends like who are managing the working as a cloud intensivist for the last 4 or 5 years. Probably they are losing their clinical skill in a way. But the thing is that it is a choice probably. Like it absolutely makes sense, like to work in both the e-ICU platform and at the simultaneously to get rotated and to do the physical work. But again, it becomes a choice. Suppose we prefer not to do a kind of stressful physical work. We prefer to do a more desktop kind of job. It is my choice. If I am more comfortable not going to the bedside, but imparting my knowledge, my clinical skill, by my clinical knowledge to somebody to take better care for somebody, it is my personal choice. And if I can pursue my career in that particular field and I can sustain and grow eventually, then that absolutely makes sense as well. So eventually probably the entire branch will come on the e-ICU or e-medicine concept. Probably another branch will come. Nobody knows. next 10 years down the line, another like we do a specialization in pathology, in ICU, in medicine. Probably the another specialization will come in the e-medicine concept. So people will get specialized. It's more stress-free. It's more like some people want to do more work from home. They're more comfortable. So if you're comfortable in that lifestyle, in that work pattern, probably the things will evolve. Nobody knows that how the things will evolve. So, but it absolutely makes sense, probably, till that time being to rotate ourselves in both the physical ICU model and the e-ICU model, not to lose the clinical touch completely, and eventually see that what exactly happens.
Yeah, that's true. Dr. Divya, my question that you showed so many studies and extensive literature. So the surgeon always say you can't do the surgery at home. Yeah, yes, Dr. Mandan. Mike.
First of all, thank you Apollo and the team for carrying out such a wonderful program. This is quite understood that it's going to be a big business in future. So there are 2 points I wanted details regarding. One is just a question for information, and second is a concern. The information will be how about the revenue sharing Apollo is planning to conduct this program into its routine. Second, the concern is we are dealing with humans. So if suppose a consultant who is online giving instruction to the staff, and the patient sees that there are some things which are wrongly conducted, a few things which were not followed, the consultant instructs or sometimes even fires. So that human interaction, how it will be conducted so that the brand of Apollo is taken care, as well as the place where the patient is admitted will also be, the patient will feel that I am at the right place. It's not going to be like mix and match. The expectation will be matched.
So I'll try to answer the question. When there is a conflict of opinion, the same thing have happened in the physical ICU. So consultant one comes, the chest physician, he says you don't give too much of diuretic. Then the nephrologist comes, he says you just give too much of diuretic. So when there is a conflict of not interest but conflict of opinion, actually at the end of the day we make a consensus which is good, which is bad, and then finally we decide. The same thing percolate to the e-ICU. So it's possible that from here I may say that you mechanically ventilate the patient. At the bedside you may say that he may not require intubation, I'll just try Navi for some time. When there is a black and white, neither you will ask, neither I will tell. But when there is a grey zone, I think actually the person who is at the bedside is quite enough sure that yes, patient does not require mechanical ventilation, you can just do that. So this will happen only very rarely, actually, once in 15 days or once a week. The fact that if somebody is happening daily out, there is something wrong. So the same thing happens in our ICU. So if you ask me, you need to make a consensus, because sometimes it's possible the question what we are asking, there is no black and white answer to that. The question what we are asking is not clear-cut answer. It's like dengue, how much time it will take to recover. Nobody can answer that question. The same thing applies in the e-ICU. So what we need to see, just use the common things commonly, diagnose the common things commonly, and make a plan which is most of the time not scientifically suitable but rational also. Regarding this finance issue, I think our finance team will meet you, but by and large, whatever we charge, suppose you are affiliated with the Apollo for the e-ICU, so there are some daily charges with GST and all that you need to pay to the system for that system actually. But regarding this conflict of opinion, this is not unusual, this is not uncommon, this might happen, but at the end of the day, that is the reason that we are doing the discussion and taking a final call. Anything you want to ask? Dr. Divya, we were talking that the surgeon always feel that you can't do surgery at home. He has to be in the hospital or she has to be in the hospital. So now taking away this e-ICU, whether this home ICU will work, that is the first question. Second, whether it makes sense that if the patient requires ICU, he or she should not be at home, unless and until there is a terminal malignancy or we know that he is not going to make it. So now there are a lot of, you see, it's like apps and all that. So now every one single day, 1 week, somebody is coming that we have started the home ICU. So whether this is scientifically rational, whether it makes sense or we have to just wait and watch?
So prior to the COVID era, we all thought that it was not possible. It was definitely the intensivist felt that unless you physically see a patient, assess a patient, it will not be possible to give an opinion. But during COVID, like Dr. Amol said, we were all forced to do that because there were a number of patients, many of whom were probably known to us, related to us, who were not able to find beds in hospital. So we started seeing these patients on the video call, giving instructions, oxygen, bed care, positioning, everything we were able to do through video calls. And many of these patients improved also without even going to the ICU. So now we know that that is possible. For definitely going to a hospital, getting admitted for certain conditions will be better. But if that is not possible or due to some reasons it is not possible, then even at home we know that we can manage to a large extent.
Yeah, so basically you need to correct the right file, you need to correct the right patient actually. Everybody can't be remotely managed and neither everybody can come to the hospital and get hospitalized. So you just need to select the patient appropriately when we talk in the context of the e-ICU. So last few questions to all panelists basically, how do you see the future ahead? That is the first thing. And what are the major challenges we face in first few days and whether it really makes a sense to work hard on that?
Yeah, so major, since we are evolving in this field, this is quite a newer technology. So the first thing is we need to understand, like Dr. Mahendra has rightly pointed, what are the challenges. We need to sort out the challenges. The major challenges will be the coordination. So the person who is giving an instruction and the person who is managing the patient, that should be a absolute coordination and synchronicity between two clinicians. And second thing is like whatever the data or whatever the input comes from that treating physician, it has to also come and it has to percolate to the person who is sitting in the e-ICU platform. So that then only this show will run. Otherwise, it will be sometimes if there is a mismatch of synchronicity or that discoordinated treatment, that leads to sometimes the haphazard treatment. And then second thing is like the keeping the relatives in the loop and counseling them regarding the care plan, care processes, and whenever to make them comfortable is also more important. To make the hospital administration comfortable and keeping them in loop for every kind of possible adverse outcome, anticipating it, and challenges which should be brought to their notice. Regular, I think the interaction and meetings should be held, and then only this whole project will take a proper shape. It is not the responsibility of the command center of the Apollo. It is also the responsibility of the hospital, and it is basically the mutual agreement, and then only this project will get more and more successful, in my opinion.
Dr. Amol, you want to say something? Please.
So when we talk about these challenges and all these things and there are drawbacks and a lot. So the thing is that we need to understand the concept over here. So the concept over here is that to make the system more patient-centric. Like when somebody is being managed in anywhere, like any remote centers or any small centers, the idea is to provide two eyes instead of one eye. So there is nothing substitution. Like it is not that the talk was going on whether it will cut down the manpower in the particular institution or not. It's not the idea. Idea is that we make people monitored not only by one person, by probably two persons, and that is always better when one patient is getting opinion from 2 or 3 different people. So that point of time, it always just changes things. It always has a kind of improved outcome. There will always be a conflict in the kind of patient care management. So medical field is nowhere in the black and white. So there is some amount of gray area will always be there. The conflicts will come in the management of the patient. But so it comes in our day-to-day practice as well. So when conflict comes, we need to talk, we need to discuss, and we need to find a consensus. So idea is to make the system more safe, more patient-friendly, more patient-centric. That is how the e-ICU concept is evolving. And that is why we need to probably adapt to our new situations more and more. Challenges will be there. There will be a kind of, it's a new field. It will advance more and more in the next coming 10 years. The system which is getting run probably now, probably the things will be much superior probably 10, 15 years down the line. But it is very important to keep ourselves flown with the technological advancement. If we do not adapt, then it will be a problem. And eventually the systems will improve more and more. And that is how the human civilization has evolved. And the medical technology, medical field will also evolve in a similar way. So that is the entire idea.
Yeah, Dr. Manoj.
See, as Dr. Mahendra was talking about the 2020 guidelines, the telemedicine has 4 aspects: that patient to RMP, caregiver to RMP, and healthcare provider to RMP, and then RMP to RMP. The tele-ICU comes under the category of this RMP to RMP or specialist. So this is telemedicine. Tele-ICU can be conducted in any nursing homes, and the patients can be managed there within the permissive framework of that remote setup. If the patient can be managed, there is a ventilator setup, and patient can be managed there, they can go ahead with the expert opinions and all that. If patient needs some invasive kind of thing and the facilities are not available, then obviously the patient needs to be transferred to the higher center. So the remote center, how the capability of that center and how is the trained facilities are there. So depending on that, this tele-ICU works. So there needs to be a lot of work to be done regarding the training aspects at the remote center, the technological aspects, and all these things should be implemented. And cost, of course, there will be a cost issue, but in the future it will be required. And to cover the remote areas where the expert facilities cannot be provided there, this will help a lot.
Dr. Amul.
Yeah, so I think this e-ICU and tele-ICU is going to be future. So currently we are discussing whether it is good, whether it is bad, how it is practical. But it's definitely, if you see like in 20 years later, it is going to be the thing in the healthcare. So for us, it is, I think it's important to get into this and start seeing how it is and how what are technical glitches and help in the improvement of this system, because ultimately this is going to be the future of the medical care.
Yeah. The last word, woman's word, Dr. Divya.
Sir, I think the main challenges that we will face in our country will be more with technical glitches and training also. Because even on-site, some amount of training will be required, and that has to be uniform across everywhere. So that will be the challenge.
Before we sign off, any question? Yes, sir, Dr. Parikh, sir. Mike.
First of all, I congratulate the organizers of this session. It has been really an eye-opening as well as a so-called a new guidance in our view to the overall things. I thank the Apollo hospitals and the ISCCM for throwing up new lights in the patient's management. I have certain ideas. We have been practicing over the years, and this concept has been totally a new one. It is the success of this particular concept will definitely go well with the advance in the peripheral centers, particularly peripheral centers, if they are well equipped, and because if you say Apollo is, I would suppose say number one in super specialized centers, whereas your peripheral centers cannot be so advanced to grasp that particular knowledge. So there would be definitely some discrepancies in the thinking and practical approach of the things. But that is taken for granted. What's most important thing, I believe, that if you take patient relatives in the loop of all these consultations, then it increases the faith in the treating doctors as well as in the system which is going on well. And the last thing I would say that it is definitely going to increase the cost of the treatment And since most of our patients are insurance based, whether it will be permissible in the insurance purview or not will be the things. Again, thanks a lot.
Yeah, thank you, Dr. Parikh, for raising this issue. Whether that insurance fellow will sanction that amount, it's in the gray zone. Really, we don't know. Some insurance, like I think HDFC or Royal Sundaram, they do that. But other insurance still they're in the, not in the pipeline, but in the premature stage to approve that actually. And thank you for your comments. Any questions, any suggestion, any other? I'll just
so just to answer your question, this teleconsultation has already come in the insurance coverage. So there are a lot of insurance company, they have come up with a plan which covers the teleconsultations as well. So in near future, once this e-ICU concept becomes more and more prevalent, then we're sure that probably the insurance company will cover the online consultations in the IPD basis as well. But OPD basis it already has come. It is there in their brochure that to cover in the online consultations, especially post-COVID. Those kind of changes in the mentality has started coming. So that's there.
OPD consultation, teleconsultation, that's fine. But over the period of time now, suppose e-ICU, the patient is there for 1 month in the e-ICU, whether that will be covered, I don't know the answer of your question, sir.
Sir, in Western countries, just to highlight on that one, in the Western countries, all of the tele-ICUs are covered by the insurance company. And because of that one, most of the population who stays in the tele-ICU or the patient base who is staying in the tele-ICU, they are getting the better services. And the number of the tele-ICU what are present in the Western countries as compared to India is more. They are totally covered by the insurances there. And as sir told, some HDFC and some Sundar, they are also trying to cover this one. See, the things are happening slow in our India, but definitely it happens. So I personally feel it's a big technology will take a U-turn and make a very good amount of care to the patients, wherever the patient is there, the best care will be get. And the day is not far when the insurance company will even give all their insurance cover to the tele-ICU.
And again, regarding your cost things, the idea is to bring down the cost. Idea is not to increase the cost. In a way, if we can adapt to the system completely, it will eventually bring down the cost. Any technology, only those technologies sustain which actually brings down the cost of the entire system. Otherwise, that technology doesn't sustain only. It usually eventually perishes in 4 or 5 years down the line. So the cost has to come down, and cost will come down. The idea in the entire digitalization process is to bring down the cost of the healthcare delivery system. So eventually the healthcare delivery will become much more and more affordable, cheaper, and then sustainable.
Yeah, ultimately the cost has come down without compromising the medical quality, actually, medical excellence. Thank you very much. Before I sign off, I request Dr. Mahendra to just felicitate Dr. Kotekar from Tata Hospital. I request Dr. Swapnil to felicitate Dr. Sudeep. Mahendra. And Dr. Mahendra to Dr. Gunadhar. Dr. Mahendra, Dr. Divya, please. Dr. Manoj, Dr. Mahendra. Yeah, I request Mr. Abhay Jadhav to come on the dais. I especially thank to the marketing department of Apollo Hospital. I request Dr. Gunadhar to just felicitate Mr. Abhay Jadhav. And special thanks to department because Apollo Hospital thought that this is a workable position system which will go for the long run. Thank you, Mr. Abhay, for your support and which you always give us, and we'll hope in future you'll continue that. That's all from our side, and thank you very much for all delegates for your time. and we'll open for the lunch.
And I request Dr. Akshay to come, and I request Dr. Amol to felicitate Dr. Akshay. He has put all his best efforts and to have a good CME and have a good knowledge platform today. So I request Dr. Akshay, please come. So we'll break for the lunch. I request all of you to please join the lunch with us. Thank you.